Make sure we're recording here before I start talking. Okay. We are great. Hi, everyone. My name is Sarah Lehman. I'm one of the co-founders of the St. Louis Play Therapy Institute, located in downtown St. Louis, Missouri. Thank you all for joining us today. Today's topic is trauma and play therapy. This is a training that is near and dear to my heart. It is one of my favorites to do live in person, which is something that we're not experiencing these days as I record the day before Thanksgiving in 2020 amidst global pandemic. So this training is a lot of fun live because we do a lot of the activities that we're going to talk about today. So what I encourage you to do is go ahead and as you're going through this training, please feel free to mark down the time that we're looking and going over a certain intervention. And I challenge you or encourage you to go ahead and do that activity just to have a sample, but also just to really get through the process and see how that activity goes. Not sure how many of you all have ever thought that an activity looked really perfect for a certain client, but didn't try it ahead of time. And then once in session, you realize that it was crashing and burning pretty quickly. I'm guessing that doesn't just happen to me, but I do encourage you to try some of these interventions prior to session. They're wonderful, and we use them a lot in play therapy. These are all interventions that I have done with clients of all ages. A little bit about myself. I am a master level social worker with an LCSW and a registered play therapist supervisor. I have been doing play therapy for a long time. As I'm counting down the years towards retirement, I've been in school social work for over 20 years, and probably about the last 15 of those years have been concentrated in play therapy. The last 12 years or so, I have been in an early childhood department, working with children with special needs between the ages of 3 and 5 for a local school district here in St. Louis, Missouri. So my specialty really is in younger students at this time. It's been my passion to work with kids developmentally as young as 12 months of age. Sometimes that developmental delay is due, in fact, to a traumatic experience that they have gone through. So today we're going to go ahead and get into it. If you have questions about the material, if I don't explain something quite clearly enough, because we're not live and able to exchange questions in the moment, please feel free to email me at any time. As you can see on the screen, my email address is there. One thing to note, you will be receiving, in addition to this at-will seminar, you will also be receiving access to a shared drive that will contain additional resources. It will also contain a summary of many of the interventions that we're going to talk about today, with a description on what materials you will need, what ages, if it's better for individual or group or family, and a little detailed summary of the actual intervention and how to do it. So that will be laid out for you as well. If you haven't gone through that drive prior to watching this webinar, I encourage you to, just to know and have an idea of what's there. Okay, you also will get a PDF of this PowerPoint as well. Okay, let's go ahead and start with our learning objectives. As you can see, the St. Louis Play Therapy Institute is an APT approved provider. On your certificate, once you have completed the quiz that you will have a link to, once you have completed that quiz successfully, you will receive your CE. For the at-will seminar, you will see that it is non-contact hours for that. Our learning objectives provide an overview of grief. We are going to touch on that and discuss how grief affects clients of all ages. We're going to go over an overview of the different types of trauma, review how trauma differs from grief, discuss how it affects clients of all ages or children of all ages, review the impact of trauma on the brain, review effective techniques to implement with clients in various stages of the therapeutic process, and that is going to be a bulk of what we're going to be covering today. Look at effective play therapy techniques to safely and respectfully support clients through the trauma narrative and healing process. Practice various trauma-focused play therapy techniques. That will be on your own, and I do encourage that. My little bar is over my notes here. provide an overview on trauma-informed therapy practices, review recent resources from the APT, that's the Association for Play Therapy, and finally, we are going to touch on the importance of self-care. All right. This is a beautiful quote by Cheryl Richardson. People start to heal the moment they feel heard. Many times when it comes to trauma and grief, as therapists, we are that holding vessel, and maybe one of the few vessels that's strong enough or has the skills to hold that grief and to hear what our clients are saying. So it's a very special place to be with a client as you walk through this process. An activity that actually is a lot of fun. It's a great way to start a family session or a group session called wordplay. Scrabble tiles seem to be the crafting craze these days. So you can buy them on bulk at Amazon, just Scrabble tiles. What I typically do is I have separated bags of 20 or so tiles. I'm a pushover, so I always have an extra bag if you're doing this in group that people can kind of trade in and out of. But the challenge is, for those of you that are familiar with bananagrams, super fun game, you kind of create your own Scrabble board in front of you. So as you can see on the screen, what you're trying to do is connect words. If you look on the third picture there, you will see family, faith, hope, love, and you see how it's all intertwined. So you try to create your own Scrabble board with the letters that you've been provided. What I like about this is it gets clients out of their heads a little bit and gets them into a playful mode, which is what we all know and love and believe to be very effective. It gets them being a little competitive. It gets them kind of not thinking about their own personal experience, but just thinking about just general words for grief. And also tapping into their competitive nature, it will kind of get them to think outside the box a little bit. So if they want a word to count, they're going to have to be able to justify why that word comes to mind when they're thinking about grief or the grieving process. So one of the words I'm seeing down here is rest. Well, they could create the word rest, but they're going to have to define exactly how rest applies to the grieving process. And it could be, obviously it could be that grief takes a lot out of you and it's important to get some sleep, or grief affects people so difficultly that they are getting an excessive amount of rest. So you can kind of justify pretty much a lot of words here. Another thing, and you just have to read your group, and again, I am a pushover when it comes to games and kids. I completely allow cheating and all of that because I work with 3 to 5-year-olds. But one thing that I do suggest sometimes, if the group would benefit from that, is they can always flip a tile over. And if a kid figures that out or a client figures that out on their own, props to them. It's problem solving, in my opinion. So if they flip the tile over, it's blank, and then they can use it to make whatever letter they want. The goal is to be able to use all 20 or 25 letters that they have in their bag. So somehow find a way to connect them all. And then what comes out of that is a nice discussion afterwards. This is a great intro activity, a great icebreaker, because that way the clients are all focused on their own board. They're not worried about who's looking at them or who's judging them, what people are thinking, or what they have to say. It's a nice little quiet 5-minute intro that can just get them working, get their brain working in a different way, and then also help them build a little bit of group cohesion or build rapport with you as the therapist if you're just doing it with you. One thing to consider, obviously, with this game, obviously spelling doesn't matter. They can say whatever they want, right? But you obviously want to be with a group of clients that's old enough to be able to spell. So my daughter, Allison, who is 5.5 years old right now, obviously this would not be a good game for her because she would be freaking out about actually trying to spell words versus the process. So, for clients that are age 7 and up, this can be a really fun game. Let's go ahead and start with grief. So we're going to look at a couple slides just defining grief and what it is, and this is going to lead us towards the discussion of how grief differs from trauma. So grief is a result of incidents of loss. Loss can be death, the loss of a job, the loss of a limb, the loss of a parent, either through death or divorce, or separation, the loss of a home. So really grief it can be anything that is the client perceives as a loss. The overall reaction to grief is one of sadness. And the reaction that the client is having can stand alone. So it is because I feel sad because we had to move and I had to change schools. Reactions the client's having are usually known to the public. So, people do understand that a change has happened, a loss has occurred. And the clients typically are okay talking about what happened. Now, the level that they will discuss it obviously varies, but they usually are okay answering questions or talking a little bit about it. The pain and sadness, again, is related to the loss itself. The child's anger is not destructive. For those of you that work in grief and loss versus trauma, there is a distinct difference in in how they express their anger. They're mad and they're upset, but they're not destroying things. There is a level that when trauma is involved, we'll get to that in a few minutes, it does take it to another level. Grief does not disfigure our identity, hurts like heck, but it does not change who you are. Yes, people grow out of the grieving process, but it doesn't actually shatter your identity or disfigure your identity. Frequently, you'll hear statements of, I wish I would, or I would not have, I wish my last words, or I wish I would have had one more play date in the house. I wish that, I would have not thrown a temper tantrum during the last dinner that we had. If it's divorce, frequently children will blame themselves. So you'll hear statements of, I wish I would, or I wouldn't have. If your client is dreaming about that grief, they tend to dream about the person who has passed away. Or who has left, or they may dream about their old house and their old school and their friends and things like that. Looking at developmental grieving, one thing years ago when I first started my career in social work, actually when I was an undergrad in the School of Psychology, the brain was the final frontier. This was the 90s. So probably the 90s when many of you were born. But for those of us that were kind of starting our collegiate or already in the professional world, there was not a lot known about the brain. So this has been an amazing journey as a clinician as we have come so far with this. But the thought was in the 80s and 90s that young children don't really grieve, they don't get it. This really is something that only, teenagers and adults know about. Obviously, that has changed. Thank goodness. We have opened our eyes to understand the impact of what young children and infants can feel from a situation. So looking at the developmental levels of grieving, at 0 to 3, yes, infants grieve. They may not understand it, but infants read the room, they read their parents. So if they or their caregiver, so if the tone of the room, if their caregiver is sad and grieving due to a loss, they are going to feed off of that energy. So they do grieve and they do miss things. That understanding obviously is going to come later, but what they are doing is they're empaths. They are going to feel that energy, that emotion. As children develop into 3 and 5-year-olds, fun, they are still struggling to accept death as a permanent process. So, when you see young children in the playroom, frequently they may be burying, people are dying, things are dying, but they're coming back. Death is not a permanent thing. So that's just where their brain is. It's very hard for them at this stage to understand that death is in fact a permanent thing. As they develop 6 to 9 years of age, and obviously these are very general, kids move through these stages at their own rate. So These are not steadfast, oh, happy birthday, it's your third birthday. You are now entering the age where you don't accept death as a permanent process. That's not quite the way it works. We all know this. But these are just general guidelines. So you can kind of see developmentally where the client is based on how they are dealing with the loss. 6 to 9 years of age, children begin to grasp the concept of death, and they understand that the person is not going to come back. So that permanence of death or loss begins to kind of solidify in their brain. 9 to 12, they are understanding that death is an inevitable part of living, that death comes at any time. It can come earlier than expected. You know, by 9 to 12 years of age, many children have experienced some kind of loss or death, be it a pet or a neighbor or family member. You know, by the time kids are adolescents, they pretty much have an adult level of understanding of loss or death, which, you know, what is that? So a lot of times faith and culture plays a big part in how clients process grief and process loss and death. One thing, my daughter was 4.5 when my dad passed away. He passed away a little over a year ago. And, you know, knowing that 3 to 5 year olds, children don't accept death as a permanent process. My daughter had experienced loss with a few pets, unfortunately, at that point. So when my father died, we, you know, obviously processed it. She's a daughter of a therapist, so we process a lot. She attended the services. And, you know, I had a close caregiver that was, you know, taking care of her so I could take care of myself and my family. You know, did all the things that a therapist would think to do while going through their own process. Well, my daughter actually was in a critical period of understanding this death process. So by chance, you know, this actually became a very traumatic event for her. She fortunately was in therapy. She sees a play therapist, daughter of a therapist, go figure. She already had an established relationship with a play therapist, thank God. So she had a trusted relationship, and she had an avenue where she could continue to kind of express herself and continue to work through it. And she's still working through it to this day. It was traumatic for her, and it's thank God I know what I know about trauma, because I was able to kind of see those signs, but just constant perseveration on, when Papa was that he died, and if she smelled flowers, it smelled like the funeral home, and just kind of talking about how later today we're going to discuss how all the 5 senses really envelop how we process and store trauma. And she went through that. Now, I thought she was young. I thought we were in an okay stage. She had a more mature understanding of death, unfortunately, because of what she had been through. So here we are, and she's working through it, and she's doing okay. But kids can go through this at all different levels. So a few books that are really good, speaking of young children and how they process grief and loss. Chester Raccoon, it's a very cute little children's series. The first book was The Kissing Hand, which talks about separation anxiety, going to school. Very sweet little series that covers a lot of things. They cover separation, they cover bullying. Acorn Full of Memories, as you see here on the screen, discusses the loss, I believe, testing my brain here, but I believe Chester may have lost a peer, I think, from school. And the class gets together to memorialize the friend that they lost. There's also one about baby siblings. I think Chester gets a little sister, maybe. So very cute series if you are looking to build up your bibliotherapy collection. Very nice. That covers, you can get a lot of bang for your buck with this series of books. Also, many of us are into puppets, although we've had to put all of our puppets away in the playroom because we can't sanitize them. So our puppets are temporarily on hold, sadly, but many of us do have raccoon puppets. So it can be kind of a nice way to incorporate a lot of things in the playroom. I'm glancing out because it is raining here again. Oh my goodness. Across from Acorn Full of Memories, The Invisible String. Very nice book. It does discuss loss. I believe their cousin, or I think it's their uncle actually, is in heaven. So that's how the book describes it. And it talks about how there is an invisible string that connects us with all the people that we love. The string can go all the way to heaven. So very nice story. Kids really do respond to it. You can get clear string, that's an elastic string, and make bracelets for children with little heart beads. So a lot of activities that you can do with that as well. The book at the bottom, Lifetimes, is actually a book that was recommended to me by my daughter's play therapist. It is a nice story. It's very matter of fact. It discusses death. Obviously, as therapists, you always want to check with the parent guardians to ensure that what you are providing with bibliotherapy is in line with what their family believes for death and loss. So in Lifetimes, the summation of that one is it just discusses that everyone's life is very similar. Animals, plants, humans, animals, I think I said that already, but they all start with a beginning, and then there's a lifetime, and then there's an end. And it discusses how all lifetimes are different lengths. So, some, like a butterfly, may have a very short lifetime, but there still is a beginning, a living part, and an ending, as it is for humans. So it discusses a lot of things. My daughter has really responded to it. Again, she's 5.5, but daughter of a therapist. So she's used to a lot of bibliotherapy books. That's mostly what's on her bookshelf. So she has really responded to it, and it's been a very easy way to touch back when she has questions. We're in the fall season right now, and we've described how the leaves, when in the springtime, there is a beginning. For those of us that have seasons, if you're tuning in from Florida or other places that don't have the 4 seasons, then it may be a little shorter or different. But here in Missouri, we have a beautiful fall weather. So we talked about how the leaves are changing and they're dying. And then they will, the new leaves will come up in the spring. So there's a beginning, there's a living time or a lifetime, and there's an ending. So it's an easy book that there's some repetition to kind of help clients get the concept, but it does cover a lot, which is great. Okay, we all know the Kubler-Ross grief cycle. So there's the 5 stages of grief. And what we obviously know is that, when you talk about kind of waves of grief, that we move in and out of the grief cycle. But it's important to just remember and understand as clinicians what that denial, anger, depression, bargaining, and acceptance can look like and sound like. And depending on what population you're working with, it's important to know how denial is going to look in a 13-year-old or how denial might look in a 6-year-old, because it's going to be different. So explore that depending on the clientele that you specialize in, and really be prepared to kind of see how is that going to express itself in the playroom. This is a great way when working with younger children, children of all ages, truly, to help do some education, some psychoeducation with their guardians or parents. They may not understand why the child's being so defiant, and it may just be that they're in that anger stage, and that's okay. It's also important for that, so they can kind of interpret the child's behavior. The other thing is to, certainly in talking with parents and also in talking with clients of all ages, that it's not a one and done kind of situation, which is a bummer. We all wish that once we were through denial, all right, I'm going to anger. I just got to work through anger, and then I'll hit that depression, sit there for a moment. Once I'm at bargaining, I'm one step away from acceptance, and I'm done. The grief cycle has been finished. I've worked through this path. I worked through the steps. We know that's not the case. So it's important to make sure our clients understand that as well, that, it's very cyclical. Time of year, holidays, things, it's going to sneak up on them. For parents, oftentimes, as their children may hit an age where they had a significant loss, that can trigger them as well. So it's important for them to understand that, it does creep back up on you. It's not a one and done situation. And understanding that kind of helps them be a little more prepared and accept it or expect it, and work through it, not think, oh, I've graduated from therapy. Well, we work through therapy, and the therapeutic process may kind of pause for a while as we have kind of graduated for that developmental level, but we always leave the door open for our clients because we know that as they mature, they're going to have a different understanding of the loss, and they're going to have more questions or need additional support. So we always leave that door open because we understand that that is a cyclical thing. So this is a really easy activity. I'm all about finding activities, finding materials that I can bring into the playroom that are cheap, easy to find. I'm a huge fan. Everyone that comes to our in-person training knows that I say Dollar Tree and advertise for Dollar Tree at least 30 times a training. Big fan of the Dollar Tree. And Amazon, of course, you can get anything there. But coffee filters, we're going to have a couple activities today that talk about coffee filters because you can buy a gazillion of them for, a couple dollars. They're great. Exploring the grief cycle with this. So each client would receive a coffee filter that was already cut into the shape of a heart. Okay, so you're going to flatten that coffee filter out, cut it out. Doesn't have to be perfect. And then what you want the client to do is select one color for each stage of the cycle. And you can have a key on another piece of paper or a Post-it note or whatever. You could even label the markers if you wanted to. So 5 colors is what you're looking for. Then you're going to have the client show what feelings they are having at that time of that cycle, of that part of the grief cycle. And they can write the word, they can make a dot, they can make lines. I'm always about letting them do what they want. So they can color it, similar to color your heart. So they could color how much of the heart they have as far as that stage in the grief cycle. Or they can think of words that come up, with the denial. What are some words that come up as part of that aspect or moment of the grief cycle? And they're going to put that down there. Then what you're going to do when they are done, and they may not have all 5. They, if they're just starting or at the front end of that grieving process, they may not have all 5, and that's okay. What I like about this activity is you can do it at any point in the therapeutic process. So you can do it and then compare them. If you write the date on there, it's something that you can kind of file away and look at later in the therapeutic process to see how it's changed, not how far they've come, but how it's changed and how they've grown. So it's a nice visual representation of that. Together, you're going to use an eyedropper. You can use a spray bottle, but an eyedropper really it gives the client a little more targeted control over where they want to drop the water and how much. And they're going to go ahead and just put it on the paper. That's going to make the markers bleed. So you don't want to use Sharpie for those. These are the reasons that we try these activities out ahead of time. One, I don't like putting Sharpies into young kids' hands because things will always go wrong. But you want a washable marker. So something that's going to bleed. The whole point is that it's going to bleed when it gets wet. And the brighter, more vibrant colors are going to show up a little bit better. The larger the dots are going to show up a little bit better. So they're going to use that water to the eyedropper to get water on there and to see how the colors bleed together, how they combine, and how grief can be messy. It's not clear cut, but grief can also, a beautiful thing comes out of it. So as the paper dries, and I always put a paper plate on the bottom to work with, because what happens is after the coffee filter dries, you have the art of the heart they made, but you also have what's left on the paper plate. And that usually comes out to look it's just a copy of what was on the coffee filter. I use that as a lesson or a moment to just comment on grief is not just a personal experience. This is your heart here, but as you can see, your feelings and your grief they affect others as well. You're in this with a community, and that's the paper plate. So it's not that they are the ones holding that grief alone. So you can kind of use the metaphor, the symbolism, to help the client understand whatever message you want to convey there. Okay, we are going to go ahead and get into trauma. Let me see. Okay, let's make sure. Yes, we are in fact recording. My worst fear is that I'll get 2 hours into this and realize I haven't been recording the whole thing. All right, so we're going to go ahead and start talking about trauma as it's defined. So some general things. Trauma is typically defined as any event that is outside the usual realm of the human experience. It is distressing. So it is something that is truly marked as a moment or an event. It can be chronic events, and we'll get into that. So typically where we see trauma coming in is it's going to bring up reactions of intense fear, helplessness, and horror. It's that sense of terror that marks trauma in the body, in the psyche. Trauma can be violent or non-violent. We're going to go through some examples in a couple slides. And like I said, the general overall reaction is terror. So all of the reactions with a traumatic event typically include the grief reactions. Reactions in children are usually not known to the public. The public may see behavioral changes, but they're not necessarily going to know why those changes are occurring. And children don't want to talk about it. And if you think that makes complete sense, if I am absolutely terrified of something, I don't want to just sit and talk about how that makes me feel. I feel like I'm going to die. You really have to have that bond. And as we go in later today, we're going to talk about the process of working through trauma. We're going to talk about the importance of building that rapport, and building that sense of safety, that felt safety. Going back to some of the behavioral changes that you may see, it's important for us to understand this and to be on the lookout for these things, because some of these behavioral changes may be typical reasons why a child or a client is being referred to therapy, and the person referring may not understand that it could be rooted in trauma. So these are things to kind of keep, make our ears perk up and think, oh, okay, let's see what's going on here. Some behavioral changes are often misread or misinterpreted as resistance, stubbornness, overreactiveness, impulsiveness, a learning disability, oppositional defiant disorder, or ADHD. Frequently, we will see, doctors wanting to throw diagnoses on children or on clients because there's some marked change in behaviors. We are, as a society, becoming overall more trauma informed, which is a wonderful thing. We're still missing things. And this is where, as therapists, we want to keep our finger on the pulse. We really want to be looking for things. If a child is misdiagnosed with ADHD, the medication, it's not going to help the child. If, the same for bipolar disorder or a mood disorder, medication is not going to help because it's not the root of what's going on. It's not a biochemical concern. It's a response to a traumatic event. And the last thing we want is for a child to be misdiagnosed, to start taking medication, to then have other changes or behavioral reactions to the medication, and then having to take more medication for those side effects. It's a slippery slope. So as therapists, we want to make sure that we are looking and supporting our clients and trying to really get to what's going on to help them a little more accurately. That did not switch. Hang on. Oh, just when I think things are going here. All right, there we go. Okay. More definitions of trauma. The pain is related to the terror, an overwhelming sense of powerlessness, fear for one's safety. So this is where the client believes that they could have died. They are concerned for their life. This is where the anger for the children or the client it becomes assaultive. You're going to see a significant increase in that aggression and that behavior. The fighting will increase. They are fighting for their lives. In their minds, that is what is going on. So they're taking it to a new level. So if you have a client that's being referred for a sudden increase in very assaultive behavior, we're going to want to look and see kind of where that's coming from and what's going on with that kid. Trauma does disfigure one's identity. When you have experienced an event that you thought you were going to die, you had zero control, you felt completely helpless in a situation, trauma will make you question things about yourself. So it will disfigure, change, alter someone's identity. And we need to be prepared to support that and help them grow. As disfiguring doesn't mean permanently damaged. Disfigure means changed. And through the work that we do in the playroom, that change can take that client on a new path, a new sense of self. It doesn't have to be a bad thing. But that's why it's important to work through the trauma so that they can actually be on a new and okay path. You're going to hear statements, it was my fault, I could have prevented it. And when you think about, and it's not just, a superhero or God complex, they really they're seeking control for a situation that was completely 100% out of their control for a variety of reasons. The client is seeking to have some control. That's a human response. If we feel like we're falling, we have a desperate need to ground ourselves. Dreams. So the dreams are about the child dying or the client dying or being hurt. That is the brain's way of processing that sense of impending doom that we're feeling through that. So we're going to go ahead and watch. This was a TED Talk done by Dr. Nadine Burke-Harris. She is a phenomenal speaker. And the video is about 15 minutes. But it is important, wonderful information. And she has a beautiful way of explaining it, much more eloquently than myself. So we're going to go ahead and play that. I'm hoping that the volume goes through. The last time I did this training live, I thought I was really big and bad and, oh so techie. And I embedded my videos for the first time. I know it's 2020, and honestly, I should have been doing this probably like 10 years ago, but bear with me. I'm old and set in my ways. So I embedded videos for the first time, and I managed to embed this video in Spanish. So if you're curious, you can actually find this video apparently very easily if you're me in Spanish. So it's out there. Okay, this one is in English. I double checked it. Before I forget, all of the videos that we are going to see throughout today, I do include links at the end of the PowerPoint. The very last slide is going to be, or very last two slides, I think it's about 2 slides, will be all the links that you can type in and find those. Okay, so you will have access to these videos if you do want to watch them in the future. They're all off of YouTube. All right.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across a lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
She She is amazing, isn't she? Oh my gosh. Okay, now I have to see if I can start. Hey, look, I switched slides. Very eloquent, intelligent, motivational, you know. So not sure. I mean, I know many of us are familiar with the ACEs. It's the Adverse Childhood Events Questionnaire that Nadine Burke-Harris did talk about. There's a copy of it in your shared drive, so you will have it. So it's broken up into basic categories. It's looking at abuse, it's looking at household challenges, and it looks at neglect. So it's those three areas that it concentrates on. When you are looking at that on the questionnaire, it says that you are checking off any of the events that happened in your life or in a client's life prior to the age of 18. And if you recall, one of the reasons they're looking at prior to the age of 18 is because they're looking at when the brain is developing the most. It is going through the largest amount of growth. As we know, the brain does continue to develop until age 25. Car companies are the only ones that really, rental car companies are the only ones that really get this. But the brain is continuing to develop, but they're looking at the bloom, the largest amount of growth. And it's because of the fact that the brain is developing so much that it's growing, and neurotransmitters and pathways and everything is being formed around the body's response to trauma. So that is why there is such an impactful, noticeable, documentable, if that's a word, concern or link to health effects. So it is a great scale to use in your practice. It is a free one. It's all yes and no questions. If you answer yes, you enter a 1, and then you're looking at your total ACE score. It's not a pass or fail thing. Trauma does affect everyone. It's an equal opportunity offender. So it's not about race, culture, socioeconomics, part of the country. It can affect anybody. So, and I know that you all working with clients of varying ages and varying parts of the country, we know that. Like she said, we are part of that movement, which is a good place to be. Okay, so that is there. We're going to move forward. And what we're going to look at is, this is just another visual representation of how the ACE scores can lead to, higher risk behaviors, further health problems, and ultimately early death. Okay. All right, so we talked about looking at different types of trauma. All right, so there is impersonal trauma, and that is, impersonal trauma is something that's beyond the person's control, okay? So this is something such as an accident, a national disaster, things like that are beyond, something that the client can actually control. Interpersonal trauma, the second type of trauma, is something that, as it says, is personal to the client. So that we are looking at assault, harassment, stalking, war, divorce, something that has actually affected the client individually. There can also be combined impersonal and interpersonal trauma. So something like a car wreck that the client was involved in, or a burglary gone bad that the client, was home during that invasion. That's something that happened beyond their control, but also happened to them. The last form of trauma or type of trauma that we're going to look at is attachment trauma. So this is, coming up with or looking at abusive relationships, including neglect. We're going to go into that a little bit more later on today. Abandonment, failure to protect, domestic violence, things that happen, that are looking at that attachment, that human connection and bond. Okay, so what can trigger a traumatic response in children? I always say this is the most depressing slide ever. So pretty much anything. anything, everything. It can, like I said, trauma is an equal opportunity offender. It can happen to anyone at any time. And as I say that, that's where that sense of helplessness, that sense of fear and terror, you can see how that comes in very naturally. You don't know when it's going to happen. That sense of the unknown, that lack of control, adds to the entire traumatic experience and event. So these are just some of the things, as many times as I've done this training and I've added to this slide, whenever I hit the what else, someone always comes up with another thing. Perhaps we're adding, a global pandemic to the slide now. So who knows? Okay. Children are vulnerable to both violent and non-violent incidents. It's important to remember that trauma is not related to the event or to the series of events. Trauma is all about how the client experiences what they are going through during that event. So it's not about the actual event. What is traumatizing to one person may not be traumatizing to another. It is all about personal experience and how they are perceiving it, how they're taking it in, how their body is remembering the experience. And if there is that sense of terror and helplessness, that is how that person is going to define that as traumatic. We are going to talk about ways that we can kind of soften and protect clients from future traumas as well a little bit later. Okay. So we're going to watch, this is a brief video. It's only 4 minutes. Dr. Karen Purvis was one of the founding creators for Trust-Based Relational Intervention, TBRI. It is an attachment trauma-informed model, not play therapy created. So, if you go to this training, you don't get APT credits. However, it is very play-based. So it is rooted in a lot of the principles that as play therapists we follow, we believe in, and we embrace. It is an amazing, amazing training. If you are, as a clinician, if you are working with foster children, if you are working with adopted children, if you are working with traumatized children, I strongly recommend that you go on their website. Their link is at the bottom of this slideshow in the references, and look into, it's a week-long training for clinicians, and it is amazing. They may even, I'm sure they're having it virtual now, so this would be a great way if you want to save on some travel expenses. If they are offering it virtually, I don't know. I attended it several years ago. It's in Texas, in Fort Worth, outside of Fort Worth. So anyway, okay, so we're going to watch just a brief video with Dr. Purvis explaining how trauma impacts the brain.
There are 6 major risk factors that can derail typical childhood development.
The first is prenatal, which is very surprising to most parents. That can be the child experienced drugs or alcohol. It can be that there was a great deal of stress. It can be malnutrition, where this mother didn't receive prenatal care or didn't have nutritious foods to eat. But prenatal harm can cause profound changes to this developing child.
We now know that cortisol, which is a stress hormone, crosses the placenta. So mothers who are in highly stressed states themselves, that stress and those cortisol levels impact their developing baby.
In fact, Dr. McEwen's research has shown that prenatal stress can be so damaging it can actually alter the structure of a young brain and impair immune functions, among other things.
A second major risk factor is the period of time at the birth. And it may be that the birth is protracted and long. The labor may be unusually difficult.
Most people are stunned at the third risk factor, medical trauma. Children's brains can interpret a hospital stay or life-saving medical events as traumatic experiences because they trigger such deep feelings of fear and isolation.
Some children go directly from birth to a neonatal intensive care unit, and they are in an isolate where they're not touched or held, but rather there are painful procedures that are necessary to save their lives. This can become a profound influence in this child's development. Sometimes hospitalizations happen when they're 3 months of age, 6 months of age, 12 months of age, and at each of these occurrences, that medical trauma becomes a risk.
The next risk factor is what most of us think of first: physical, sexual, or emotional abuse.
Abuse can take form many, many ways. Neglect. Most parents are surprised to hear that neglect is as harmful as abuse. The child who's neglected has as much change in the brain development and brain chemistry and ability to trust as a child who was abused. The message of abuse is, I don't like you. But the message of neglect is, you do not exist.
Finally, there are natural or man-made traumas: a car accident, a plane crash, a flood, or a fire.
Was the child in a natural disaster? Was the child in a situation where they experienced, for example, 911 over and over again? In any of these risk factors, we find global changes are possible to the developing child. Every part of their development can be touched, can be altered, can be damaged.
Research shows that children from hard places can be developmentally less than half their chronological age, so an 8-year-old may act more like a 3.5-year-old. A 15-year-old may be more like a 7-year-old in development and behavior. Understanding how your child may have been damaged by early trauma is the first step toward turning his or her life around.
Here you go. Good job.
Okay. Make sure I can. Oh, I did it. Okay, that went a little easier than I'm getting better at switching slides off of video. So Dr. Purvis just had a beautiful way of describing things. One of the most profound things I learned, and she touched on in this video, was the impact of neglect on a child's brain development. You know, I kind of came up in my clinical career, my education, thinking that physical abuse, you know, or something that's happening to the child's body had to be the worst thing in the world. And, you know, hearing her say that, you know, physical abuse will say, I don't like you, but neglect, you're not even worthy of me hitting you, is what she's saying. You don't even exist to me. And that hearing and understanding and wrapping my mind around how damaging neglect is to the human psyche, to one's identity, is just so disheartening and impactful to me, and frustrating as a social worker in the schools, you know, and a mandated reporter. When we make calls about neglect, it is so hard to know how impactful, how much that is changing and affecting this child. But it's so hard to prove, and so hard often for many states to respond to that, and to, you know, actually have a child protected from that. Another phrase you heard her say, and you'll see me writing down, so we are taking a quiz at the end of this, and what I'm trying to do as I'm recording today is, you know, based on what I'm talking about, typing up my questions or writing out my questions on the side. One of the things she did mention, the phrase children from hard places, and this is something that the Karen Purvis Institute, that's what they call, or how they've identified children that have been through a variety of events in their life. So children out of foster care, children out of international adoptions. They do a lot of work with, you know, the attachment concerns revolving around children from international adoptions, children from domestic adoptions, children that are adopted out of the foster care system, or children that are existing within the foster care system. So children from hard places really kind of just identifies kids that have come. They have a story that needs to be told. So they're coming from something that has happened to them. The other thing that we will kind of continue to touch on today is the developmental delay that trauma can create or be the cause of, often a half-age delay. Parents forget that. You know, children that they talked about infantile and birth trauma, a child that has significant delays at birth due to whatever reason, you know, prematurity or just medical interventions, things like this, you kind of always, you have that understanding that for the first 12 months until their actual, like 12 months from their real due date, you know, you expect a delay, society expects a delay, and then we kind of forget about it. The child begins to hit their developmental milestones and kind of, you know, begins to develop and progress and do amazing things physically. But we have to understand that delay in, sometimes it could be in speech, it could be in their behaviors, in their emotion, their ability to regulate emotions, and in their physical growth, who knows, that trauma can impact, it can actually create up to a half-age delay. So oftentimes we will get referrals for clients and the parents are exasperated, or the teachers are exasperated with how immature they're acting. You know, they're 10. Why are they acting like they're 6? Why are they acting like they're 4? I frequently hear from families I work with that, you know, I work with a lot of children that have the 2E kids, the twice exceptional kids. So they're very, very gifted cognitively. And you can hold, I love these kids, because you can hold amazing conversations with them. They are advanced beyond their years. You know, that when they are in the upstairs part of their brain, when they decompensate or become dysregulated, these children can go from acting age, if not above age, to suddenly returning to infantile or toddler-esque meltdowns. And it's very disconcerting to parents and to teachers that are trying to work with these kids. So, you know, they just don't understand it. Why can I talk to them like they're 8, and then once they're in the middle of a meltdown, I have to actually revert and change my support of this child to that of a 4-year-old and not an 8-year-old. So the more we can educate parents into how, and teachers, you know, I'm a school social worker by day, the more we can educate them on how trauma affects the brain, the more understanding they will be. You know, that's when the paradigm shift will occur and they will see beyond the behaviors. Okay, so looking at trauma in play. So frequently what we will see is repetitive play, and they are playing out the themes or the aspects, parts of the traumatic event. So, you know, when we learn about how play is shown in the playroom and how play is shown throughout the life cycle, we repeat things until we feel mastery over them. So if you can imagine, if you put that onto with a trauma lens, you look at that and you think, you know, a traumatic event where something is completely out of one's control, and think of all the things that are so confusing about that and so, you know, misunderstood. And how do you wrap your head around something that you didn't see coming and you felt completely helpless about and terrified about? So frequently you may see, or you may think, oh, this client is stuck. They're not moving, you know, they're just stuck in this rut. And what we need to look at clinically is, are they stuck, or are they truly just repeating this, trying to understand what's going on? And we will talk about interventions for, you know, how to give therapeutic nudges and kind of test that out and see where the client is later today. You will also see the trauma-specific reenactment. So they may actually, act out either with toys in the sand tray, with puppets in the playroom, things that actually happened in the trauma. This is them out of their body, third person, trying to make sense of this. Some themes that you're going to notice with abused children can include, of course, lists are never all inclusive, but themes around protection and safety, regression, trust and betrayal, nurturance, perfection, guilt, anger, chaos, connection, confusion, grief and loss, and limits and boundaries. If you can hear my dog snoring in the background, I do apologize. They are chilling on the couch, and one of them is having a dream about running, apparently. So hopefully he'll catch that squirrel. So these are some themes you're going to see in the playroom, things to kind of look for. Okay, so looking at play in early trauma. So, oops, hang on. I'm losing there we go. Okay, so in looking at how play is going to affect a child that has experienced early trauma, a traumatic event is going to, just as it interrupts physical development, it can interrupt play development as well. So it's not uncommon if you see for someone that has experienced an early traumatic event that their play may be stunted, and they may be kind of stuck in some regressive play because the body just kind of stopped at that point due to that event. So you may see symptoms of that could include, re-experiencing the traumatic event over and over again, emotional numbing. They kind of just become just numb to everything because they've been flooded by so much intensity for so long, or because of the event. There can be physical, not just play regression, but there can be physical regression or loss of developmental milestones. A child may withdraw or avoid, or you may see that hypervigilance, that increased arousal. Like Dr. Harris-Burke mentioned, it's okay to be hypervigilant and to have cortisol rushing through your system if you are in the woods and there is a bear. That's effective. That's survival. It's not so effective when a child is in a classroom trying to learn and someone drops a book and they shut down and they go into hypervigilant mode because they are having a flashback of what happened to them. So that increased arousal can be very detrimental to kids. They may engage in repetitive post-traumatic play. That's their effort, like I mentioned before, for them to try to make sense of things. Before we can process emotions and how we felt about something, they need to have their trauma narrative in line. And we're going to get into the stages of therapy, and we will cover, working with clients of all ages and helping them develop their trauma narrative. Paris Goodyear-Brown is an amazing play therapist and trainer that talks about tons of interventions and ways to work with traumatized clients. And one of the things I remember her saying in one of her trainings years ago, we always talk about, the client needs a push. Well, we don't want to say that we're pushing a client. And she said, sometimes we need to give a therapeutic nudge. And I thought that was a very gentle way of, kind of letting that client know, I am here for you. I am here with you. It's time to get into the work. We aren't going to do that until we have the rapport and we are into the client has a sense of felt safety. But I thought the therapeutic nudge is just a nice way of thinking about that. Okay. We talked about some of the behaviors, the poor attention span, concentration, And through that, you can kind of see how sometimes these students or these children are misdiagnosed as having mood disorders or ADHD or ODD, when in fact it's just their body is affected, their learning is affected, and their behaviors are affected by a traumatic event that we just may or may not know about. Okay, so this is just a quick review, some basic facts about grief and trauma. We've touched on all of these, I'm sure. Let's just review to make sure. So anyone can experience that. Like I said, it's an equal opportunity offender. You don't have to understand what's happening to be affected. So, and that's where sometimes society, it's where we kind of go astray. Oh, they didn't see it happening. Looking at the below one, you don't have to witness it in order to be affected. They weren't there, so it's not going to affect them. We know that that's not true. You know, things that are complicated or what we think is above a child's, ability to understand doesn't mean they're not going to be affected, and they can't be traumatized from something. We talked about the trauma affecting the five senses. We're going to go into that more. We did that. Okay, struggle with understanding regardless of age. And I think that's important to remember. We're all struggling to understand what has happened in a traumatic event. It's not about age. With age, hopefully comes wisdom, but when it comes to trauma, it's a leveler in that sense. So it's going to be confusing for all of us. And that can be kind of a normalizing thing to help parents and clients understand, you have every right to struggle with this. This is a very difficult thing for anyone to wrap their head around. The last one is when the human body has been activated by trauma, the right brain overrides the left brain. So that's kind of referring to, it's more of the experiential, the five senses, how things are perceived versus logic, versus reasoning. So the whole logic kind of gets thrown to the side and the right brain can take over in this sense. Okay. I have a couple notes. Sorry, I'm kind of looking through this. I want to make sure we get all this in. So one thing I had noted, when a child lives daily life in the experience of feeling unsafe and powerless, a wide range of PTSD reactions can develop, including physiological symptoms such as stomach aches or headaches, emotional, such as helplessness or hopelessness, behavioral, such as aggression, we touched on that earlier, and cognitive difficulties that can include problem solving or focusing. So we talked about kind of the attention span there. This is just a nice list. Oh my goodness, a list of signs of complicated grief in children. I apologize. You can see complicated. It kind of goes into the next line. Try to get fancy with these slides. So signs that you kind of want to look out for. These are signs that you might hear parents why they're referring their child for therapy, and you're kind of just keeping a mental track of this going, I wonder if there could be something traumatic that has occurred. Nightmares and bedwetting, conflicted relationships with family members, outbursts of rage, feelings of unworthiness and despair, poor grades, impulsivity, or difficulty concentrating, poor eating habits, isolation, difficulties in relationships. So when we hear that, this is a significant change in this child, we're not quite sure what happened, our mind is always thinking what could have gone on. And the beautiful thing about just having a trauma-informed practice or a trauma-informed approach, it's a gentle, considerate way of working with all clients. So whether they have experienced something or not, we don't have to know for sure. Have you been traumatized? Yes or no? Okay, if yes, we're going to go this way and we're going to do the trauma route. It's a way of guiding your practice that's just inclusive of things that could have happened. And you don't have to have concrete answers for clients still to benefit from these interventions as a whole. These are some lists of traumatic childhood grief. So a child who has lost a loved one to a gory or unexpected or violent death. This is loss that is also traumatic, and it's because it was done, that loss was in such a significant, gory, graphic way. So if there was interpersonal violence, a motor vehicle or other accident, suicide of a family member or a friend, or a classmate, that can be a successful or unsuccessful suicide. I had a client when he was 3 walk downstairs and found that his dad had attempted to shoot himself, and he did not complete the suicide. But it was very graphic, for that child to see, and he could describe and draw pictures and give every detail of the sight, the smell, just looking at the 5 senses, what he experienced with that. So it wasn't, he didn't lose his dad at that point, but it was still a traumatic association with suicide. Natural disasters can, literally uproot things, or acts of terrorism. So these are all ways that, a child can experience grief, but it's a traumatic grief. Okay, we're moving on. Okay, so this is, myths about loss and grief in children. These are things that aren't true, but are they're commonly heard. Grief is private. No, it does not have to be. It shouldn't be. Grief should be shared, and hopefully someone that is grieving has a sense of community so that they can share that with someone. Children don't grieve. Well, we know that that's not true. They grieve at any age. It may look different, but they do grieve. It's possible to replace the object of loss. We know that's not the case. I'm a big animal lover, and what I hear people saying, or people have said to me in the past, oh, well, you can just get another dog. Well, I will get another dog. Back when I lost my last dog, I got 2. But that doesn't replace the loss. So it's not about, trying to replace something. I think grief makes us feel uncomfortable. Not as therapists, I'm saying as a society, grief makes us feel uncomfortable. And, as a caregiver, as an adult, we want to help, and we want to make the child feel better. That's our goal, right? That's our goal as therapists, is to help people feel better. But it's not going to be about sunshine and rainbows all the time. So I think frequently they have good intentions. What they're trying to do is just alleviate that pain. Oh, here's a puppy. That's not replacing the loss. If the parent starts dating again after a loss, one, that new dating partner is not replacing their loss at their level, but it's also not going to replace a parental figure for the child either. So it's not about replacing it, but it's very commonly people do think that. And it's just an effort for people to want everyone to feel better and copacetic. How many are guilty of this one? Ways to manage grief is to just stay strong, keep busy. Things will get better with time. Knuckle down, pick yourself up by your bootstraps, one foot in front of the other. My parents were Depression era children, and they were raised with that philosophy. Absolutely. You just don't talk about it. You just, put your head to the ground and you go, you work. Great work ethic. My parents were both very driven, very successful adults, didn't process their feelings very well. So, there's some good aspects to that makes them wonderful, faithful employees. However, not the best way to deal with your emotions, and certainly not the way we deal with grief now. Okay. We are going to Usually in the live training, we have interventions that kind of intertwine through all of this. And I'm going through my binder. I still have my little binder of notes. And I'm seeing all these interventions. We are going to hit those. Don't worry. They're going to be later this afternoon. And what I was able to do, since we're not actually creating things, and you guys can take breaks as you want by hitting that pause button. We don't have to have, working breaks and activities. And we don't have to have drying time for some of the things. So we're actually able to put all of our activities into the stage of treatment that they should be in. So it's going to make more sense for you guys, but it's a little more fun for the people that come and see this in person. Okay, we are going to watch a 12-minute video, excuse me, about children from hard places and the brain. So this is, again, out of the Karen Purvis Institute. And it's going to talk a little bit about that. We're going to go into some information about the brain and then some brief screening tools. So we are getting close to entering the stages of treatment. Hang in there. All right, so this is going to be a 12-minute video.
As recently as the 1980s, scientists believed a child's brain at birth was fairly static, largely predetermined by genetics. Researchers now know that's not true. While genetics clearly play a role, scientists know that relationships and experiences shape the brain. Think of a developing brain like a multi-storied house under construction. In this chapter, we'll explore the basics of brain development and help you understand how early traumatic experiences can design a different house. When we're born, our brains are teeming with more than 100 billion neurons or brain cells. Under optimal conditions, when our needs are met consistently by nurturing caregivers,
You got a red ball.
our brains thrive. These neurons connect in complex and vast networks, much like the electrical wiring in a modern home.
The baby comes with all this wiring, but it's the human interaction. Looking into the eyes, being held, hearing the song of my mother, feeling the strong shoulder of my daddy, that began to make the brain develop in very, very important ways for all of the life skills that will come.
At birth, the lower floors, or the downstairs part of the brain, is firmly wired in place by genetics, allowing a child to breathe, eat, sleep, and hear. Survival functions are rooted here. Very few connections in the upper floors are formed. These more sophisticated parts of the brain govern higher functions: complex thought, reasoning, emotional processing, memory, speech, and most importantly, the ability to regulate our behavior. It takes time and repeated experiences for this circuitry to develop and become hardwired in the brain. When a child experiences trauma, abuse, neglect, or other risk factors, it can skew the wiring of the brain, as well as the structure and the chemistry. The lower, more primitive survival part of the brain can overdevelop from reacting to fear, while the critical upper floors may underdevelop and suffer.
In the book that I wrote with Dan Siegel, The Whole Brain Child, we talk about an upstairs brain and a downstairs brain. For some kids,
Dr. Bryson is a psychotherapist at Pediatric and Adolescent Psychology Associates, Director of Parenting Education for the Mindsight Institute in California, and best-selling author along with Mindsight Executive Director Dr. Dan Siegel.
the upstairs brain is the more sophisticated part of the brain. It's our cortex that takes a long, long time to develop. And it's the part of the brain that allows us to regulate our emotions and calm down our bodies, understand ourselves, understand other people, and really be able to make good choices and be flexible and adaptive. The downstairs brain is much more primitive. It's actually really well developed at birth, and it's the limbic area and the brainstem connected to the body. And that part of the brain is much more reactive, and its job is to kind of constantly be watching for how to keep us alive.
Dr. Bryson's research and studies in attachment science child rearing theory, and interpersonal neurobiology have made her a sought-after expert contributor with appearances on Good Morning America, PBS, and Red Book magazine. She says trauma triggers the watchdog part of the lower brain, called the amygdala, to work overtime.
And its job is to constantly sort of scan the environment, to be paranoid a little bit, to be watching, is everything okay here? Am I okay? Am I safe? Is anyone out to get me? Can I relax? And that part of the brain is always appraising what's going on around us, reading faces, reading the environment.
Do you like bubblegum? Yeah.
No.
When children feel threatened or overwhelmed with fear, they may fight, run away, or shut down. The brain kicks into survival response, which researchers called fight, flight, or freeze survival mode. If the brain stays in this state too long because of trauma, it reorganizes around survival at the expense of healthy development of other parts of the brain.
So for a child who's had repeated exposure to fearful experiences, whether those be sort of a trauma like a car accident, or whether it's developmental or relational trauma, where the caregiver was frightening or they were left for long periods of time to manage their own fear states. The downstairs brain has gotten a lot of practice being active. It's the repeated experiences that we have that actually activate growth and connection in the brain. So if a child has had a lot of experiences where their downstairs brain that was reactive and fearful, that part of the brain gets really well developed. Whereas then the upstairs brain that knows how to calm that fear and kind of do that self-soothing, like, oh, that was a scary noise, but I'm okay now. That part of the brain may not be as well developed in children who have had repeated fearful experiences.
The impact goes beyond the upper and lower floors. The fear and stress of trauma also affect the left and right hemispheres of the brain, which help coordinate logic and emotion.
The left brain specializes in logical, literal, linear, and linguistic, which is using words, and those modes of processing information and going about in the world. The right hemisphere, on the other hand, is much more closely connected to emotion, to sensations in our bodies, to kind of looking at the whole picture as opposed to bits and pieces, and more random ways of processing information as opposed to linear. And the important part is that they work together as a coordinated whole. When children are in situations where their needs are not responded to, where their emotional states are not understood, or there is not a caregiver who responds consistently, quickly, and in an attuned way, the right hemisphere does not get nurtured. It doesn't get developed optimally. So when one side takes over, we can either be cut off from our emotions or we can become flooded by them.
It's not just our emotional balance that gets upset by trauma. It also disturbs the delicate balance between our brain chemistry and the hormones that drive our central nervous system and our entire being. In times of stress, our bodies produce the hormone cortisol, revving our bodies to a state of high alert. Periodic stress and short bursts of cortisol actually stimulate growth and help us adapt and change. When stress stays too high for too long, toxic levels of cortisol become corrosive and can lead to a host of long-term problems. Rockefeller University neuroscience professor Dr. Bruce McEwen is noted for his pioneering work on the impact of stress on the brain.
In a chronic stress situation, our lab has shown that dendrites in some parts of the brain, like the prefrontal cortex and the hippocampus, will shrink and communication will be impaired.
Most critically, Dr. McEwen says chronic stress takes a heavy toll on the vital front part of the brain that controls emotion, memory, and attention.
The prefrontal cortex is very vulnerable, and when there is chaos in a child's life, lack of good attachment, development of the prefrontal cortex is severely affected. And it's involved in the downstream control of everything that's going on, whether it's impulsivity, whether it's aggression, anxiety. It helps control mood. It helps a person make decisions when to stop something, to do something else. It's the brain area that is so important for self-regulation, which is so important for success in in everything that we do as adults.
Dr. McEwen is a best-selling author, former president of the Society for Neuroscience, and expert contributor for the PBS series This Emotional Life.
Early life adversity and toxic stress is often associated with increased frequency of disorders like obesity, diabetes, cardiovascular disease, as well as brain problems such as substance abuse, antisocial behavior, depression.
When a child stays in elevated states of stress, that cortisol stress hormone washes over the brain and washes through their body. And we know that brains that are exposed to chronic cortisol look different from healthy brains.
And I'm wondering if we can outline the paper.
Doctors Karen Purvis and David Cross have conducted extensive testing on children who have experienced early harm. They've found severe imbalances in cortisol and neurotransmitters. Neurotransmitters are the chemical messengers the brain sends the body. Some excite and some calm, and trauma can dramatically upset the balance.
A young child who is getting optimal care has a balance in the brain chemistry. The chemicals about I'm afraid, I'm hungry, I'm cold, those are called excitatory, are balanced when the caregiver comes and gives warmth. And then the chemicals about I'm safe, I'm fed, I'm loved, we call those inhibitory, come into play. And so this child has excitatory but then inhibitory. So there's a balance in the brain chemistry. If a child has early trauma or harm, even brief early trauma or harm, these systems become imbalanced so that I'm afraid, I'm hungry, I'm scared, I'm lonely takes precedence. And there's very little of what would come when the needs were met. For children that we have seen over the years, and we've done neurotransmitter tests to test the level of this chemistry on more than 2,500 children. And what we find is dramatic levels of excitatory neurotransmitters, dopamine, beta-phenylethylamine, norepinephrine. We find glutamate that causes seizures very high in many of the children.
And research shows these imbalances also raise the risk for mental health issues and lots of behavioral issues. The takeaway message is this: trauma damages the brain, especially a young developing brain. It alters brain structure and upsets the delicate balance of brain chemistry that drives behavior. It puts a child at risk for a lifetime of problems.
I'm sorry.
But if you know the risk factors that predispose a child to harm, you'll be in a better position to quickly intervene and minimize the damage. Up next, key risk factors. Some may surprise you.
Okay. All right, so they do a much better job at describing the brain and talking about left and right and upstairs and downstairs than I do. Every time I watch these videos, and I've seen them quite a few times, it triggers something. I remember, oh yeah, that's right. And like I said, you have the links of all of these, so you can watch them again. Okay, so looking at additional interventions that are really just pro-brain, I cannot promote enough Dan Siegel and Tina Bryson's book, The Whole Brain Child. They also have the Whole Brain Child workbook. So it's a way, this is a handy thing. I have referred parents. I have a lot of parents that they feel better feeling like they're in control of their child's therapy if they have something to read. So offering, if they do want the book, that's great. But the workbook actually has all that information and has exercises as well. And what they're looking at in the book is ways to match your parenting or your intervention style with where that child is in their brain at the moment. So you do, if the child is in the upstairs part of the brain, things that you can do to work on psychoeducation and all of those things, the calming skills. However, when the child goes into the downstairs part of their brain and they have decompensated You know, it's, as Gary Landreth says, you don't try to teach a drowning child how to swim. So the book and the workbook offer interventions and suggestions for parents in a very easy to read. It's not, you think, oh, it's all about the brain and neuroscience. Very easy to read, but offer suggestions and interventions for how to co-regulate with your child or co-regulate with your client. And really just, you know, help them feel safe again and help them return to the upstairs part of their brain again. You know, as Dr. Purvis mentioned, you know, that balance. It's not about protecting our clients or children from anything that could harm them, but it's about balancing that when they are, that when that excitatory event does happen, there is some inhibitory that comes and calms them down. So that balance. These interventions, it's a nice little list of things that are wonderful for working with the brain and can be very easily brought into the playroom. Brain gym is something I was trained in probably the 90s. You don't hear about it as much. Maybe you guys have, which would be great. But you can look it up online. It is all about getting the brain to communicate with each other. So left side, as I use my right hand, but it's your left side, I think. Left side of the brain communicating with the right side of the brain. You know, you want the brain communicating across, and so you're using the entire brain. You have the whole brain child. How do they get that title? Okay, so Brain Gym does a lot of crossing midline, which is on there as well. Crossing midline activities are amazing for kids. There's a lot of fun ways that you can do that. That is a developmental milestone. Be aware of that. So young children, developmentally, if they are under the age of, 18 months, 2 years of age, all the way up to 3 years of age, they have a hard time crossing midline. So if you ask them to touch their ear opposite them, what they might do, see if I can, is they'll hit midline and then their body will start moving. And they'll look a little bit like a dog chasing their tail. I came across that with some of my developmentally delayed students. And when I realized that, I was like, oh, okay, we need to kind of do some more integrative work with them. So there are things that you can do. We are going to do an activity later today, and you guys have a page of a lazy 8 that if you stick your thumb straight out right in your center and you go up and around and then cross midline and over. Obviously, for a person that can cross midline, they can do an imaginary or invisible lazy 8. But there's ways that you can have a lazy 8 as a mat on a table where they can drive cars around it. You may have to have the lazy 8 on one side of them at first, and then you slowly want to bring that so that the center of the 8 is at their midline. There's ways to accommodate for that to help them slowly come over and cross midline. I do a lot of brain hugs with kids where you hold your earlobes, so just your earlobe, but you cross over and you gently squeeze. We're not trying to, take out earrings or cause headaches here, but you just give gentle pressure. And then what you will do, which I am not going to do for you right now, as an example, you do a squat. So you breathe in as you go down, and as you come out of your squat, you exhale. What that's doing is it's adding up and down movement with crossing midline movement. It's a lovely integrative ritual that you can add to the beginning and ending of your sessions if you'd like. I start groups and end groups with those sometimes. Mindfulness can be an amazing thing. We have a wonderful training about mindfulness. We're going to touch on it very, very briefly here today. Briefly, I mean like maybe a couple minutes. But mindfulness activities are wonderful. It's all about just grounding the client, getting them here in the present. And when you think about how trauma affects a child's ability to think rationally and logically, they're stuck in what has happened in the past, reliving it very possibly. bringing them into the here and now can be very powerful and very helpful for them. So mindfulness activities are great, and we're going to go through a lot of those activities, but we're not going to touch on the details of mindfulness today. Balavizics by Bill Hubert is, I have just gotten into it, and it's something that I really want to, it's on my list of things I want to get trained on. I don't know if you guys have a list of, ooh, I want to do that. Ooh, I want to get certified in this. Probably because you're play therapists, you're already in advanced certification for things. I keep a list of things, and Balavizics is one of them. So this was developed by a PE teacher, actually. Education-based, but very, very cool. If you go on YouTube and just search it, it's all about rhythmic movement, and they use like racquetballs, very, very cool exercises it can get either a client or a group of kids in sync with each other and moving. I think Bruce Perry is there's a short clip with Bruce Perry coming up here in a little bit. One of the things he talks about when working with traumatized individuals is just rhythmic rocking, things that are repetitive and rhythmic in nature help to rewire the brain. So it's a way of counteracting what the traumatized brain has been developed around. So that's where Balavizics is very powerful. You hear about rhythmic drumming and drum circles and things like that. Horseback riding, things that are rocking chairs for infants or swaying with infants. Those are all, it's that rhythmic patterning that can be still distracted in a training with my phone, right? I apologize. So that rhythmic patterning can be very beneficial in rewiring the brain and repairing the brain. I think we got that. All right, there's the lazy 8 activity right there. This is an example, and we're gonna go ahead and do it right now, actually. So with the lazy 8 activity, the way I do it is I have this mat, I laminate it so that it can, I have kids use these. These are actually in all of my mobile sanitizing play kits that I'm using right now. I don't have kids. I have all individual play kits for my clients at this point, just for sanitizing purposes. And working in the schools, we're preparing for going virtual at any given moment these days. So, but this lazy 8 is actually in all of my play kits. One, I use the laminated sheet as something that you can like mash Play-Doh on. As you can see with the lazy 8, you can drive a car around it. You can drag your finger around it. There's lots of ways that you can incorporate this. For this activity, what you do is you take a bottle of hair gel, and I did not color this one, so it's not going to be that graphic to see, but you put that in a freezer quality Ziploc bag. So in that you can add, 5 to 10 drops of a soothing color. I had someone in a training use red food coloring and got it really dark, and it was a little more graphic than, it wasn't as soothing to me as I think she was going for pink. But you can color it, most of mine I make are either like a calming blue or a calming green. The point is to color the hair gel, but then you want to still be able to see through it. So when you have this lazy 8 mat underneath this gel bag, they can run their finger on it, and it becomes just a sensory experience. But it's also for kids that may be adverse to messy play. It's a nice way for them to get the benefit of touching the gel. Here I am playing this. I'm going to be playing with this for the rest of the day. Touching the gel and not getting messy. So great way of doing that. What you're going to do when you make this is you take a full bottle of hair gel, smash it into a Ziploc bag, seal the Ziploc bag. These are things that I only say this because I've done this the wrong way a couple times. You're going to fold after it's sealed. Fold that over, and you're going to stick it in a second Ziploc bag. I have trust issues. I don't want hair gel all over. I borrow people's offices when I'm in schools. Nothing says don't invite me back, like leaving mashed up Play-Doh and a splooge of hair gel all over a carpet of a director's office. No bueno. So double bag this sucker. Once you double bag it, you find some awesome duct tape. There is a million patterns, super fun. Kids are in love with it. They're making prom dresses out of it now. And you're going to duct tape the heck out of all 4 sides of the Ziploc bag. So what that does is it kind of secures all the weak points of these Ziploc bags where they can possibly break. And it also frames your little sensory mat. There are, if you look on Pinterest, there's sensory mats that you can make, and you can have beads and things like that in there. For these, the purpose is for you to be able to lay that over an 8 and motivate the child by adding the gel to kind of work on crossing midline. So I don't put any beads in it. I do color it because it makes it a little more fun. If you are pro glitter, this is a very divisive concept in our community. I am anti-glitter. It gets stuck in my hair for years. So I am not a glitter person, but if you are, and there's a bunch of you out there, add a little glitter to that gel. You know, you can give that a little bit of food coloring to color it, but you don't want it to be opaque. You want it to still be clear so you can see through it. So that is the Lazy 8 mat. Great, fun little intervention. The reason I have mine here that is not done is because I promised my daughter that we would make it together when she forgot about it. I brought it home like a week ago, but she's going to see it out today. So it's for us to do later tonight, I'm sure. So that is the Lazy 8 mat. And there's directions about this in your shared drive in the intervention document. Okay, looking at the DSM-5. So these are the trauma and stressor-related disorders. You have your PTSD. With the DSM-5, they acknowledge the preschool and then also the dissociative as subtypes: acute stress disorder, adjustment disorders, reactive attachment disorders, and disinhibited social engagement disorder. It's just important to know kind of the words and where you're looking diagnostically when we're working with trauma. This is a list of some of the screening tools that are out there. Some of these are the ones that are free are in your shared drive. The ones that are copyrighted are not, because that would be a no-no. So there is a variety. If you are, depending on what you need your screening tools for, depending on if you're in private practice or part of a diagnostic system or a school system, everyone has their preferences. But these are just a list of some of them. So there's the Childhood Trust Event Survey. There's also, what is nice about that one is there's animal related experiences below that. So there's another kind of version of that survey. We've talked about the ACEs, the Childhood Trauma Questionnaire, Trauma Symptom Youth Checklist, and then another one for young children specifically. Additional preschool assessments for those working with younger kids. The Child Behavior Checklist, or the CBCL, is rated for children as young as 1.5. So there's a preschool version of that. It is a separate scoring sheet and a separate tool. So you can't use your school age CBCLs or teacher report forms for that one. There is a separate preschool one, so you can buy more of them. But it's a great rating scale. The Trauma Symptom Checklist, that's the bottom one, has the one that's rated for young children, which is great. The Devereaux is another common one, Devereaux Early Childhood Assessment, and then the Vineland Adaptive Behavior Scale. So these are all, I'm trying to think, from the pediatricians as far as rating scales, and I usually get these because they're looking at ADHD. The Child Behavior Checklist is a very common one that pediatricians will give to schools or therapists to complete. And then also the Vineland is very popular. So those are ones that you're going to want to kind of look at. Okay. We are going to, here's Paris Goodyear Brown. I mentioned her briefly earlier today, but she is a phenomenal trainer. And this is something, another TED Talk her talking about trauma and play therapy, and she just has a beautiful way of describing it. Oh, unless I bypass the whole thing. So this is a
It was Plato who said, "You can learn more about a person in an hour of play than in a year of conversation." I am a play therapist, and nowhere is this more true than when I'm working with traumatized children. I'm going to share with you this afternoon about play and trauma and the power of one to heal the other. So when I went to graduate school for clinical social work, I already knew that I wanted to work with traumatized children. I learned some valuable things in my graduate program, including how to do differential diagnosis, how to do a suicide risk assessment, and how to do fairly traditional talk therapy with regulated grown-ups. I did not, however, learn what to do with a 3-year-old who is trying to pee on me from across the room, or a 6-year-old who is trying to stab me with adult scissors, both things that happened as soon as I got into my first job out of school. So I was desperate for answers for these children. And I went to my first conference on play therapy. It was hosted by the Association for Play Therapy, and it was in Orlando, Florida that year. And I fell madly in love with the field and really do believe that play is the primary language of children. And for traumatized children especially, the play is their talk and toys are their words. I'm going to give you an example of that up here on the screen, but first I'd like to lead you in a very brief exercise. If you would turn to your neighbor and share one of your most embarrassing experiences with them. Okay, I'm not going to really have you do that. And everyone's relieved. But what if, instead, I had said, turn to your neighbor and share your most shameful sexual experience? I think you would have been hard-pressed to do so, right? And if we as high-functioning grown-ups find that difficult, how much more challenging is it for the little ones who have limited experience and limited vocabulary? So this is the play creation of a child who's been sexually abused. He came into my playroom, he undressed the baby doll, he got the doctor's kit and started to fix it, and after a couple of minutes of intense fixing, he sighs, and then he goes over, gets the spider, he puts it on the private parts of the baby, and he says, "Miss Pewith, take a picture." He doesn't have any words to describe his abuse experience, but he can create an evocative image that communicates visceral volumes to us. So I remember being in my first play therapy workshop and seeing slide after slide of this kind of art and sand and play creations, what I now call the glimpses and snapshots of trauma that children gift us with along the way. And the speaker was helping us to become kind of bigger containers for the story, so that when a child gives us a glimpse of trauma, I can say, "I see what you're showing me, and you can show me more. I see what you're showing me, and you can show me more." I was hooked, armed with this new understanding that children can articulate the unspeakable through play. I returned to my little inner city school office and turned it into a playroom. Very soon after that, I had a young lady come to school who was wearing the same clothes she'd been in the day before, and she was bouncing off the walls, which was highly unusual for her. So I pulled her aside, and I was pretty quickly able to get the kind of superficial, linguistic, linear narrative of what had happened. Her mom had gone out to do her second job. She had forgotten to leave a key under the mat. And my client and her sister had spent the night on the front porch in a very violent neighborhood. When she comes to school the next day, I'm not going to try to therapize her right away, right? Maslow's hierarchy of needs. First, I make sure she has a good meal. Then I put her on a cot in a darkened room for a couple of hours and let her sleep, because if she had any sleep at all on the front porch, it was hypervigilant sleep. And only then do I bring her to my playroom. And even then, I don't ask her to give me more details of the scary thing that happened. I introduce her to the tools of play. And she goes directly over to the child guitar and starts to strum, pretty frenetically at first. But as she calmed, I invited her to create a song. And this is her creation. So it hurts inside so bad. This is why we do the work that we do. I was aghast at this child's ability to take those tools of play, combine them with her story, and get to deeper and deeper levels of emotional expression. This was a pretty sophisticated telling. I have lots of other children who don't have any words to describe their abuse experiences. And some of that has to do with the way trauma gets stored. It's more in the right hemisphere than in the left, and children already live more in the right hemisphere than in the left. Trauma also gets stored iconically and somatically, so in pictures and in our bodies. So the ways in which we invite children to show us and tell us have to honor those ways in which we store trauma. Johnny is one of my best examples of that. Johnny was playing in the living room with Legos when his mother's boyfriend barged in, high as a kite, grabbed the first thing he could find, which happened to be a clothing iron, and bludgeoned Mom repeatedly until she slipped into unconsciousness. The children thought she had died. She did not die. She, in fact, made a remarkable recovery. But at the time that they came to see me, the children were living with their grandmother, and Mom was recovering in the hospital. And so the first day he comes to see me, he draws a picture of Mom that looks like this. So you see the tears coming down Mom's face. You see the wide open mouth where she's crying for help. He also talked about there being blood on a pillow. He then went over to my home living section and he took a little wooden iron and he said, "Miss Pewith, can you draw this?" So I drew the iron. And then he looked at it for a minute and he went and got the purple Play-Doh and he stuck it on the iron. What is he showing us? What his words cannot. It would take me some time to get to the gray matter of the brain stuck to a household object, right? But he was able to tell us quickly through his iconic expression. So it's these insidious encodings of trauma that hijack us when we least expect it through a little thing called the amygdala. The amygdala is an almond-shaped cluster of cells in the midbrain that are sort of the seat of somatosensory memories as they relate to heightened emotional experiences. So if you have had a joyful memory, the day you got married or the day your baby was put in your arms for the first time, you probably have some crystal clear sense memories of that event. So the taste of the wedding cake or the smell of your new baby's head, if that is true of your joyful memories, then it is doubly true of the things that terrify us. We are not meant to hold the atrocities that we are often forced to hold. You have a fist come at your face and hit you. The next time a fist comes at your face, you duck out of the way. The thing is that the amygdala is a pretty sloppy processor, and so I like to unpack this using a little army guy. I'll say to the kids and their parents, let's pretend like this guy is in Iraq, and his job is to take care of the tanks. So he gets up in the morning and he's washing the big windshield of the tank and he hears gunshots, bang, bang, and he drops to the ground. His heart starts to race, he freezes, he doesn't move till it's over. When it's over, he checks himself and he's safe. He didn't get hurt. The next day, he and a buddy are out there trying to get the mud off the big tread tires of the tank. And again, he hears gunshots, bang, bang, and they drop to the ground. His buddy doesn't drop quite as fast and gets a little bit hurt. He's okay, he just needs a Band-Aid. But our guy drops really fast, and that keeps him safe. And that happens day after day in Iraq. And after a year's tour of duty, he gets to come home. And he's been home for maybe 6 months, and he's out at the mall doing some Christmas shopping, and he is laden down with packages, walking in the parking lot, and he hears a car door slam, bang. What's he going to do? And 5-year-olds can tell me he's going to drop to the ground. We just don't do it with scientific jargon and tell children, your brain becomes habituated to the stimuli. We don't do that with kids, but we can give children and their caregivers permission for the idiosyncratic ways that children tell us about trauma. We call this post-traumatic play, and Bobby is really my best example of this. He was 4 at the time that he came to my playroom. He had grown up in domestic violence for the first 3.5 years of his life. Mom and Dad then split, and he lived with Mom. Dad would come to pick him up for visits. One day when Dad came to the front door, he seemed calm and regulated. He asked to use the restroom. So Mom said sure and let him in. The dad took Bobby in the bathroom with him, locked the door, and then he shot himself. Bobby was trapped in the stuff of the trauma for about 15 minutes. So when he first comes to my playroom, he goes directly over to the red finger paint and he mucks around in it. And then he goes over to my water source and he washes his hands. And then he goes over to the red Play-Doh and he mucks around in it. And he goes over to the water source and he washes his hands. These are called cleansing rituals in trauma play, and we see it when children have a full body dirtying experience from their trauma. They then need a full body kinesthetic experience of being cleansed from trauma. I could tell you more about Bobby's play process. It was pretty amazing. When he became more regulated and I could give a more directive prompt, I invited him to choose from the miniatures on the wall a toy to be his mom. And he chose a nicely dressed woman with a cake, pretty nurturing. I invited him to go and choose a toy to be himself, and he chose a disproportionately small naked baby, which I think shows the vulnerability and the chaos of the aftermath of the bathroom. And then I said, go and choose a toy to be Dad. And he gets all the way over to the shelves, and he turns to me and he says, Miss Pewith, can I choose more than one? And I said, you can do whatever you need to do in here, which is my standard response. And he chose 3. He chose a giant aggressive wrestling figure, a little nondescript kind of wimpy character, and Prince Charming. What is that? It's the domestic violence cycle. It's what I went to graduate school to learn about. It's what we see on the billboards on the side of the road. This 4-year-old was more expert in the domestic violence cycle than I will ever be, not having lived through it. He did not have the words to show us, but he was eloquently able to articulate the 3 faces of Dad in his play. And just because children have words does not mean that will be their chosen form of expression. So I learned this from Danny. Danny is an 11-year-old boy who was growing up in significant neglect, maltreatment, lots of sexual abuse in his background for the first 5 years of his life. Then he moved in with a wonderful adoptive mom, and afterwards came to see me. And he's already taller than me when he comes in 3.5 months into treatment, and he says, I want to wash the babies, and points to the tub on the top shelf. I say, okay, we're going to get the tub down. So I bring it down. He fills it with hot water and soap. He gets a baby doll and undresses it, and he begins to wash the head of his baby. And as he washes the head of his baby, and he's looking at it, he says, my mama used to shove my face in my baby brother's shit diaper. And I say, that sounds like a really important part of your story. Thank you for sharing it with me. And I believe so strongly in these glimpses and snapshots of trauma that children gift us with along the way that I keep little sticky notepads under everything at Nurture House. And so I grab one out and I extend the moment of holding the story with him just a little. My mama, and he comes around behind me and he wants to make sure I get it right. And I would suggest to you that he was only able to tell me about that humiliating, shaming experience because he was actively engaged in washing the baby. The play itself mitigates the approach to the trauma. So why is play so powerful this way? Well, it helps us to understand a little bit about bottom-up brain development. So the reptilian brainstem begins to grow first in utero and is responsible for breathing and heart rate and respiration. All the basics, keeps us feeling good. The limbic brain or feeling brain grows over that, and then eventually the thinking brain or neocortex grows over that, but is highly underdeveloped in human babies at birth. So Becky Bailey, a developmental psychologist, created an elegant pairing of simple questions with each part of the triune brain. So the reptilian brainstem is always asking, am I safe? The limbic brain is always asking, am I loved? And then the thinking brain is asking, what can I learn from this? But if the lower brain region questions aren't answered satisfactorily, then the thinking brain is offline. I was deeply convicted that I wasn't giving enough yes to these children yet. So I went in search of sweet, cozy space that would answer those lower brain region questions. Am I safe and am I loved? With resounding yeses. And that became Nurture House, the trauma treatment center you see on the screen. Everything about the way that Nurture House is put together is based on our most current understandings of the intersection of the neurobiology of play and the neurobiology of trauma. At any given moment when you walk into Nurture House, you will hear laughter and see high fives. You will see kids eating and jumping and playing for their lives. There's a secret drama unfolding beneath the surface, an epic neurochemical boxing match in which the stress hormones and the joy hormones are vying for primacy. And play gives the joy hormones a leg up. So how does it do this? Well, this is my picture of cortisol. Cortisol, and I don't know what it means that this was my son and I took the picture before I took the cortisol-inducing thing off his head. So cortisol is the stress hormone and is needed in our bodies for us to move forward. I probably wouldn't have been here on time today if I didn't have some cortisol. But when it is released in massive quantities in our bloodstreams due to overwhelmingly terrifying events, it can make us sick. And it's responsible for a lot of the big behaviors that we see in traumatized children. If this is a picture of cortisol, then this is a picture of oxytocin. Oxytocin is the bonding chemical, and it's released between mom and baby while they are nursing. Joy chemicals, dopamine, are also released and are enhanced through competency and mastery experiences in play. So when a baby is in a mommy's arms and he goes, "Akaka," and she goes, "Agu," in that moment, the baby learns that he can impact the world, that he has a voice, and that he matters. We want as much oxytocin and dopamine on board during trauma recovery as we can get. So play becomes the digestive enzyme that metabolizes trauma. How does this digestion happen? It's bit by bit, and it's in the presence of an other. So play can help to tell the story, but the story has to be heard and held. Maya Angelou wrote, "There is no greater agony than bearing an untold story inside of us. Sharing it with an other helps to leach the toxicity out of it." I have the great privilege of getting to be an other for the children and families in my care. You have the great privilege of getting to be an other for those in your spheres of influence. So I would leave you with two questions. Whose stories are you meant to hold? And how do you bring your playful presence to those around you? Thank you.
Okay. Paris Goodyear Brown, I strongly encourage checking her out. She has a large YouTube presence. But now with so much virtual training, you can, if you go on the APT website and you go in their e-learning section, that may or may not be available only to members, I'm not sure. But they have an e-learning site where they have a lot of their previous international annual conferences, and you can actually watch big names in play therapy and get CEs for them. So that's a great way of seeing them, or, handy dandy YouTube, which is great. All right, guys, so we've made it this far. We are going into what a bulk of the rest of the training is going to be. We are going to work through the following 8 goals of trauma therapy. So this is going to be our map that is going to take us through, and we're going to cover play therapy interventions for each of these stages. These goals of trauma therapy were taken from Paris Goodyear Brown's book, Play Therapy with a Traumatized Child. It is a great resource Bible to have on your shelf if you're working with a lot of traumatized kids. Additionally, on the APT e-learning page, you can read books, specific books, and take tests questions that they have on there for non-contact CEs. And this is one of the books. I think it's worth maybe 8 or 10. I'd really be challenging my mind to say I knew exactly what it was. I don't have it sitting right here. So, no, I thought I did. Oh, wait, I think it's 9. Oh, no, that's a different book of Paris Goodyear Brown's. Never mind. We'll get to that later. I digress. Wow, I can be ADHD even on at will webinars. Great. Okay, so we're going to go through this step by step. Here we go. All right, so the first one, and the reason I have this slide is just so you have a rundown of where we're going. So let's get into step 1. All right, so the first stage or goal in trauma-focused therapy is building a sense of safety and security. We've touched on the need of this a little bit earlier today. And, you know, obviously, this is, like I said, this is a great roadmap for kids that have or not necessarily had been exposed to trauma. We are starting our therapeutic process with all of our clients, building that sense of safety and security. With kids that you suspect have experienced trauma or with kids that you know have experienced trauma, this is a crucial part that you cannot rush. That makes it hard. We are working in a very solution-focused system. Insurance companies expect results. Parents or guardians expect results. Clients expect results. You know, they're not feeling good and they want it to go away. Teachers expect results. So, and then, you know, we put our own pressures on ourselves as well. So this is a very important step to really drop that anchor, slow yourself down, and make sure that you have covered your bases. All right, so the first bullet point there, well, okay, before we even get into the bullet points, so how are you guys prepping your clients for therapy? Depends on the age that you're working with. And there's a lot of, now that we're in a much more digital useful using age, I don't know. There's a lot of things that we can do that's very easy. Old school, I write a lot of visual stories. I use PowerPoint as my platform for that. But I think, I mean, now there's Boom slides and Google slides and, you know, all these other terms that these young kids are throwing out these days. Old school, you know, I do it on PowerPoint. But you can write a very simple story about going to play therapy. There's a few books on Amazon that you can purchase that describes what the playroom is. I like creating it myself just because then I can insert pictures of my actual playrooms, my actual toys, myself. If I send a digital copy to the family ahead of time for the child to review, they can insert a picture of their child in, which for younger children will get a little more buy-in. So a visual story can be a very effective way in order to prepare the client for therapy. This is also a way to explain what you're going to do in the playroom to the parents. So parents don't take in all the information that we give them at intake. You know, they have a lot on their mind. They're trying to get that information to you, and they're not going to remember everything. The great thing about a visual story or a social story is that it gives parents a repetitive script to be able to read with their child. So when I send home visual stories, the term social stories is actually trademarked by Carol Gray. And she has a very prescriptive way of using social stories as a learning tool where you read it there's a whole routine and structure, and they're great. I'm not so structured. So we call them visual stories, but I would assign the visual story to the family to say, you know, I want you to go ahead and read this before dinner time or at bedtime. You know, but I want you to read this once a day with your child. Or I want you to have this book available to your child in the car so that they have, you know, they're looking at it while they're driving. You're obviously not reading to them while they're driving because that would not be safe. On PowerPoint, you can record your voice, so it actually could play the whole story if you wanted to do it that way. or a YouTube link, whatever. So a visual story can be a very effective way of making sure that the parent is describing what the goals of therapy are, what your playroom is going to look like, what your expectations are in a very consistent way. Touring the playroom, the first time a child's in the playroom it shouldn't be their first session. They should have at least seen what your playroom looks like ahead of time before you're asking them to separate from their parent, guardian, or teacher. So for a tour of the playroom, virtual tours are the thing. If you have a website up, my goodness, get that virtual tour out there and let parents click on that to see and use that video and that tour of your space that we work so hard in preparing. Let that video really speak and sell your practice and what you have to offer. So you can do virtual tours, appointment cards for the client. Even if it's a child. And I know a lot of places we're getting away from appointment cards because I just put it right in my phone. I'm sure everyone else is doing the same thing. We're telling Siri to remind us or set a date, whatever. But an appointment card for a child can be a very important thing for them. So if you do have a stack of business cards that have appointment cards on the back because Vistaprint was doing that for free for the longest time and now you're just not using them, this is a great way. Give that to the child, and let them know. It shows that that they are important. So those are just different ways of prepping kids for the playroom to kind of give yourself a little jump into, so that when they do arrive at your office for the first time, you're ready to kind of get to work a little bit. Okay, first bullet point, child-centered play therapy and TheraPlay are amazing models to follow to encourage a sense of security, a sense of safety with clients. Child-centered play therapy is, giving the child the lead. Sorry, I have to sneeze here. So in the days of COVID, you can't sneeze anymore without, having it turn into the Salem witch trials here. So I feel the need to apologize. Okay, so child-centered play therapy is a great way to kind of put the child in charge. Give them control, which is going to help them feel more comfortable. It's going to help them show you where they want to go. TheraPlay is also a phenomenal resource and model to use. The TheraPlay Institute up in Chicago may be offering trainings virtually now. Again, I don't know, but they are an excellent resource to look into. Their interventions are incredible. They're great. Working in early childhood, I use a lot of their interventions with kids. So also going back to child-centered play therapy, I don't want to slight them. So looking at Gary Landreth's program down in Texas, they have you can get certified in child-centered play therapy. Phenomenal program. Some of that may be online. In fact, I know they do have online at-will trainings. So the benefit of what we're going through right now is we're all getting a lot more access to training. So those would be great things if you're looking for more training in there to definitely look into. Guided imagery of a safe place. Now this is where my book, I think it goes with Fox and Rabbit. Okay. We are gonna, we are gonna go through all of these things. So we're just gonna click right through this and we're actually gonna hit on all samples of all the rest of these in different slides. Okay, so Fox and Rabbit apparently is the first intervention that I have on here. It's not correct in my binder. It's throwing me off. This is something that we typically will do in the live trainings. Very simple to do, but you get a lot of bang for your buck with this intervention. So not a lot of materials, no prep time, but you really can develop some therapeutic rapport with this and some assessment of the situation as well. You need a piece of paper, okay? You want 2 different colored markers. They should be, don't get like a sepia and a red, pick 2 very different color markers. Client's gonna choose one color, you get the other one, or it can be done with 2 group members or family members. And they're gonna take the turn of who's the fox and who's the rabbit. Okay, so the rabbit is going to be running from the fox, which means they are going to be going first on the paper. They're going to put the pen to the paper or marker to the paper, and they're just going to start drawing and just kind of pretending that they're a little rabbit and they're trying to stay away from the fox. So they're going any which way. As they start, the fox is going to pursue them. So the second person with a second color marker is going to follow in their path closely, but not catching the rabbit. We don't need to create additional trauma, right? We don't need the fox to go after that rabbit. So the rabbit is going to always stay safe. Fox is going to chase him. What this does is it's a silly game. It helps, them practice being the leader, practice being the follower, which is good for both child and adult to take turns with that. It also, as you're kind of moving around, you're going to bump and have accidental physical touch. You can assess at that point kind of how the child is, if they're comfortable with that, if they flinch, where they are with that, to give put your finger on the pulse as far as where they are and how comfortable they feel. And it gets silly because you're trying to avoid them and, oh, wow, I'm going to get you. And it just becomes like a cute little playful, easy activity. So that's fox and rabbit. Now without my binder, this is like, ooh, what's next? Okay, learning to bear it. So this is another intervention that, you can use. The first time I saw it described to me, they were actually like using a marker on a teddy bear. And I don't know who has indefinite funds to be purchasing all these teddy bears, but get a piece of paper, draw or print a teddy bear on it. What you want the client to do is identify who their safe places are, who their safe people are. And then you can write it, they can cut it out of a magazine, they can write it or draw a picture of the person, whatever, but you're identifying who they feel are their safe people and their safe places. This is giving you just an assessment of what's going on and how strong their safety net is. They can write the people, they can write contact information, depending on their developmental level. It's just a way for them to help them understand that they have a community that's supporting them. Identifying a client support system. So this is this is the support tree. This is what happens when, because there's a coping tree later. Okay, so this is the support tree. This is a neat activity to do with clients of all ages. And, some kids love to get, their hand just all in that finger paint, and get their hand right on there. So you're going to want to you can make a pretty big tree. If you don't have access to butcher paper, things like that, you can use thumbprints instead of a whole hand. So you can still do it on an 8.5 by 11 piece of paper. So this is something that the client or the group or the family they want to fill their tree with all of the people that are in their support system. So this is something to help them feel like they're not alone. They have supports. There are people out there that can be part of their tribe, be part of their support system. If you're doing this in a group, as like your initial session, I would encourage you to be prepared to make a picture or take a picture of it so that even if you electronically send it to all the kids in the group, they all have their own copy. But it can be, you can have this tree and then you can write your group norms on the trunk if you want, and kind of just tie that all into some of those intro activities that you would do with a group or with family sessions as well to kind of set those boundaries. Obviously, we have the family members or the group help you come up with the norms so that they can have an additional buy-in for what they're doing. So that is the support tree. Draw your safe place is a great activity. It's kind of just a free draw where you just ask the client to draw your safe place. Draw a place where you feel safe. For those that maybe Adam Sandler fans, I might be the only one out there. In Happy Gilmore, his movie when he is he's a golfer that I can relate to, because that's kind of how I golf too. I tap into my rage issues. Apparently, I also horrible at golf. But he had his happy place where he would go, and it was, I think his grandma was there, and whatever, lots of other things. So draw your safe place. They can also describe it to you. You can have them for kids that aren't, for younger kids where drawing might be difficult for them. They can, scrapbook with old magazines, find some things, or just, talk about it if they want. But drawing your safe place, you just want them to kind of come up with a place where they feel happy and secure. And that can be anything from their closet at home, a cozy cube from school, the beach. Although some kids don't know what the beach is, it might be their swing set or, in their bedroom. So it can be anything at all where they feel safe and secure. This is actually a handout that is in your shared folder, my safe place color bubble. So this is just I love that it's kind of a generic kit, very simple, and gives the child some freedom to decorate and color as they want. But on the handout, it actually says, I can imagine a color that helps me feel safe. I can image the safe. There's a typo on this little worksheet that I did not make. I can imagine the safe coloring filling the air around me to help me feel peaceful and calm. I can breathe the safe color into my body. So this is a nice guided imagery, very simple activity that you can do with children where they can start just, putting a feeling of safety and attaching a color to it. Okay, before we get into phase 2, I'm going to pop back up here. And we have a couple extra notes I want to make sure I get in here for you. Okay. Okay, some additional ways to kind of create a sense of security. You obviously want to make sure that this is going to be a much harder process if the child is still involved in a domestic violence situation. So you do want to make sure that the child that there is, a sense of safety at home or in the community. So you don't want to, say, oh, of course mom's safe, and when the child doesn't believe you, because the domestic violence could still be going on. So identifying people that are safe can be very helpful for that child, knowing that they might be returning to an environment that's chaotic and traumatic. Paris Goodyear-Brown in her work talks about, in a training I went to years ago, she discussed the importance of providing a tangible takeaway for clients when working with kids that have experienced trauma. And the thought process behind this was, when kids can be emotionally numb or dissociative and having a hard time grounding themselves because their brain is processing so much other heavy stuff, having a takeaway helps the child, and it doesn't have to be anything huge, but having just a small takeaway helps the child realize that your experience did happen. The time with you did happen, and it could be an appointment card, and it will happen again. So it gives them a concrete representation of the work that you're doing. Easy little things can be story stones, little tiny painted rocks, marble, obviously not for younger students or children that are going to swallow it. So you need to be mindful of that. Obviously a rock in the hands of a child with impulse control issues isn't a great idea either. Every great idea can possibly go wrong in some way with some clientele. But thinking of, small tangibles, it could be like the bracelets that we talked about with the hearts on there from the invisible string, a small craft project that you made, or, when I am working with clients, sometimes I'll make a feeling stone or a worry stone with them out of model magic if I'm, feeling really rich, or out of Play-Doh. So if you take Play-Doh, it will dry, That will take a week. If you have a week in between sessions, you're going to want to give it a week for it to dry, and then they take it home. But that's kind of a neat, cheap way that they can have something. Or again, story stones are awesome. I also use, they have 2-inch diameter wood chips, which I really like because they're big enough that you can write a couple words on there or like glue a sticker on there. And they're not heavy like a stone, they can't break, things like that. So a wood chip with a word or a sticker or a symbol or even their color, their safe color that they chose, just painting that on there and having them take that home. Those tangibles help the client it brings home the concept that they matter and that your relationship matters, your time with them matters. Working with parents or with schools or group homes, it's all very difficult. Working with the guardians to establish safe and consistent environments at home or school can be extremely valuable. So talking to families, teachers, guardians about routines, about having a safe place in the home that siblings can't go to, something that's just for that child, or, who their safe people are. So in a school environment, for example, knowing that, if they identify the custodian, if you want to find who the best friends are, it's usually the custodians because they take time to say hi to every kid. My kiddos always love the custodians. They also see them after they trash the room because the custodian shows up to clean up and long stories. But custodians in the schools, secretaries, the lunch people, these are all people that can be a child's connection, who they look forward to seeing. So finding out who those people are in different environments so the child knows who they can access and where can be very valuable. All right, let's go into step 2. Okay, so let's go into step 2. So phase 2, the second step of working with traumatized clients is not only assessing their level of coping skills, but increasing, teaching, strengthening their coping skills. The thought process here is the client first has to feel safe, and you have to have that rapport. Once you have established that sense of safety, not that that's not going to kind of wax and wane as they go through and delve into their trauma, but you want a foundation there. As you move into the second step, looking at their coping skills, the reason you want to see what their level of coping skills is that you want to ensure that they have defenses, appropriate, adaptive, effective defenses to provide, like the picture says, that self-care, that protection before going into the muck, as Paris Goodyear Brown described that. A nice, easy definition that someone, no clue who, told me about what an adaptive coping skill is, because a lot of times, especially if you work with older clients, teenagers, they have coping skills. They may not be the best or a safe choice, but the fact is they are doing things that are working for them. The kids I work with, they are doing things that work for them. When they need attention, they're getting attention. They know how to do it. It may not be the most effective, greatest thing, but it is working. It has served a purpose for them. We're not there to take away maladaptive coping skills from kids or from clients. To take that away would be putting your client on the tightrope or the trapeze and saying, hey, I'm going to take away the safety net so we can put another one in its place. No. You're leaving the original safety net there. Now, you may have a better safety net, which is what our coping skills, our adaptive coping skills are, but you're not taking away the safety net first. You are putting your safety net, your coping skills maybe above theirs And when the client has said, yes, I trust that that safety net is there for me, I trust that these coping skills are going to work, because it's telling a kid to take a deep breath. I mean, I don't know about your clients, but mine tell me exactly what they think about that sometimes. And it's amazing the language that can come out of 3 to 5 year olds. They're very expressive. So once they, using that metaphor of the trapeze or the tightrope, once they have accepted that your safety net is going to work for them, then that's when you pull out the old safety net, the maladaptive coping skills. So we are replacing, but we're doing it slowly and at their pace. Okay, so in looking at these, adaptive coping skills. Okay, write this down. Easy way to remember it, 3 parts. An adaptive coping skill, because they'll challenge you. Well, this works for me. Well, okay, well, let's see it. Let's see if it measures up to the 3-prong approach. Is it good for you? Is it good for others? And is it easy to do? So, my coping skill, riding horses. Is it good for me? Yeah. Is it good for others? I mean, if I'm in a happy mood, yeah, it's good for others. Is it easy to do? I don't have access to a horse in my life. So did it hit the 3 prongs? It didn't. It needs to be something that we can do. You know, a kid may say riding his bike. Well, at school, that may not be feasible for them. Now, if you're in one of my schools in the early childhood department, we have kids riding up and down on trikes all the time. Sometimes we have physical therapists, or sometimes I might be a little bored and I'm riding up and down the hallway in a trike. So sometimes, you know, it can be easy to do. But those are the 3 things. Good for you, good for others, easy to do. Okay. I kind of like that. It's a way of a meter, a way of measuring it out. All right. So we're going to go over these. How many are there? 7 activities, play therapy, things that you can do to work on assessing and strengthening their coping skills. Okay, and looking at the family play geogram. Oh, it has been a day. That's a genogram, Sarah. All right. The family play genogram, this is a very easy, simple, fun way of kind of seeing where the family is. I know we all love our genograms, and there are times I'm over 20 years out of grad school, and I don't do all like the proper coding or anything, because I never really learned that, but I still do my circles and squares. And some of the families I work with, I know some of the families you guys work with, they have a lot going on. So I have to map them out just in my files to kind of keep things straight sometimes. So with this one, you're going to map out just the basic genogram. Now, if this is a session with a child, it's going to be how they identify things. Or if you really want to kind of put out who you know, you don't need to get into like their lineage here. But here we have a mom, a dad, big sister, them, the client, and the little brother. Okay, easy family. You're going to ask them to select a miniature that represents each family member. Great. Here's what I love about this. It tells us so much. In the video with Paris Goodyear Brown, when she was talking about, how the miniature that the child selected, so much of that is telling. If a client wants to put more than one in there, I'm going to allow them to do that. It's what they need to do. It's not only the selection, it's the process of selection. So if you guys have been trained with sand tray or sand play, if you're looking for a great sand tray training, we offer a fantastic one, and it's in the process of, I think, being recorded as well, but we're struggling to still make sure we have live labs so people get that experiential part of it. But great training in sand tray. So it's not just about what they actually pick. It's about how they pick it, what they look at, what they might touch first and then put back. Also placement. If you're looking at the picture on your screen, you see mom's half in, half out of her circle. Dad's tail is piercing mom's circle. Might be accidental, might not be. You have your sacrificial lamb as your client. I think that's a hippo for a little brother. Big sister is growling and looks like it's about to devour the client. It tells a lot. So it's just an interesting way of kind of seeing what that family dynamic looks like. Eliana Gill did a training years ago. I feel like that's my standard response. Years ago, back in the day, but she came and spoke at the annual Missouri APT conference. And she had a 2-day training on trauma and ways to work with children. And one of the things that she implied, and I keep pointing at my screen like I have a pointer here, but I don't. She also suggested that then you draw, in addition to doing this, you draw a line in between to represent the relationship. So this is where you're going to want a bigger piece of paper because it's going to get messy. But you would draw, for example, a line from the lamb to mom, dad, brother, sister. Brother would then have a line also to dad, mom, sister. Dad would have a line to everyone. So everyone has a relationship with each other as well. There's a line. And perhaps you need to color code stuff. It gets messy, like I said, spread it out. Then you would pick what Eliana Gill sometimes does, she said, was she will have them pick a miniature that represents the relationship between each of those individuals. Very telling, great information that you can get from that. But also it would get a little crowded and confusing as well. So just a little twist on there that you can do. With the solar system, and we had an example of this and I went through the office trying to find, I couldn't find it. I have no idea. Things get, they get misplaced. But for the solar system, obviously you're not going to be using mirrors or sharp objects, but what you would do is you would have the client draw a picture of themselves in the center of the paper. Now, if they want to be the sun, they can be the sun. Why not? But then what you want is to do, and you can have stickers of stars, the little cheap foil stars, or you can draw them. You can do dots, like with a bingo dotter, whatever they want to do, whatever is easiest for them developmentally. You're going to have them assign a planet or a star for their supportive family and friends and have them all around them. Now, the nice thing about this is you can see, obviously, there's additional information you can gather by where the client puts themselves on the page, how big they are, how powerful they feel, or how minuscule they feel. And then you also can assess who they put closest to them. So who are the big planets? Who are the shooting stars? Who are the meteors? Who's at the edge of the page? Who's closest? Who's in their inner circle of support? This is a nice way of gauging who they find supportive and how supportive they find them. Who did they leave off the page? They may have forgotten someone, or they may have intentionally not put someone on there. You could also follow up with the same activity later to talk about who the client wishes would be a support system for them. And that wish fulfillment is a part of therapy. I may have a relationship with my brother that I wish was stronger. So if I could have, if my ideal brother could be on this page, what would I want him to look like? So you can kind of open that door of possibilities for them as well. That wish fulfillment aspect can be there too. Okay. Our coping tree. So this is it's just a neat activity. Now, for those that have been trained in art therapy, this is just, they're apples on a tree. You can use any kind of fruit stickers that you can find at Dollar Tree, but they do have stickers. And the thought is that you have a tree, and then the client is going to go ahead and assign stickers. They're either going to go on the tree because they're a healthy coping skill. So good for you, good for others, easy to do. Those get on the tree. And then some that fall short, like my little horseback riding wish, are going to fall off the tree. So they're going to be kind of the rotten fruit. They didn't quite make muster there. Okay. So adaptive, effective coping skills on the tree, other coping skills that aren't good for you, good for others, easy to do on the ground. Okay. So teenagers, smoking. Is it good for you? No. Or vaping. Good for you? No. Good for others? Well, they don't really care. You know, it's an e-cigarette. Okay, well, put up my middle finger because it's step 2. So it's not good for you, but okay, fine. Good for others. They don't really care. It smells good. All right. Easy to do. Well, you know, I have to buy it. My parents took it away. I mean, whatever. But it's not going to make all 3. So, okay, well, you know, we can put vaping. So that's a sticker. So does it pass the 3 or does it go on the ground? So that one would go on the ground. This activity is a neat way of not poo-pooing any of their coping skills. You're acknowledging them and you're having them, with your encouragement, assess whether or not it hits the 3 stages or 3 qualifications to get onto the tree. So you're not saying that they, you know, no idea is a bad idea, but does it go on the tree or does it go on the ground? So it's not assigning it's a good or it's a bad. It's just, does it go on the tree or does it go on the ground? So you don't have to call it rotten fruit. You don't have to have like rotten fruit stickers. You know, it's just one of those. Then ultimately what you have is a coping tree of skills that you would like them to use. So that could be homework, as you know, you might want them to write down or circle the fruit for each one that they had used that day. They can circle any of the fruit stickers so you can kind of gauge on how many adaptive fruit on the tree skills they're using versus how many of their other ones that are more comforting or familiar to them that they're using. That is the coping tree. Crowning community, and actually I have a, this thing has been through the ringer. There's a pipe cleaner attached to it, who knew? So you can do this in a variety of ways. You can go online and just print out an easy, like, what am I thinking? Cut out, you know, blank template. Thank you. Here we go. A blank template of a crown. I had a bunch of just paper crowns. I think I got from like a teacher supply store one year. And then it had some little people cutouts that I used for this one. So this was kind of my sample. The thought is that either on each of the peaks of the crown, or they can attach people with names on it. But all the people that have been supportive in your life can go on the crown. Now they can go on the inside, on the outside. You can have them choose, like some people might be silent supporters, or some people might be more outwardly supporters. So the silent supporters, if they want to acknowledge them, but they don't want them to be on the outside of the crown, they can write them on the inside of the crown. Places you want to kind of tease out is who are the supportive people in their home, in their community. It could be their church environment, their workplace, their school, sports teams, doctors, you know, boyfriends, girlfriends, whatever. Tease out different areas and kind of help them dig a little bit deeper so that they can come up with a more full community. This activity, 1, I like to color, and 2, I like to eat cupcakes. So, you know, it's kind of a win-win. So with the cupcakes, you can easily decorate this as a handout. Working with younger kids, I don't do a lot of handouts. I do a lot of as much hands-on stuff as I can, 3-dimensional things. So this would be something that I would do either with like cutout pieces of the cupcake with Velcro, kind of make it a puzzle, or an overlaying thing, or I would actually decorate a real cupcake because yum. I wouldn't bake with kids, obviously. So, but 3 to 5-year-olds, not great for sharing food. We all know how hygienic they can be. So with this one, so on the handouts, it actually says, you know, things that help me feel calm. So maybe that's, you know, the color of the wrapper color the wrapper with things that help you feel calm. Places where I feel calm and safe, that might be like sprinkles or the icing on top of the cupcake, and maybe they get a different color icing or a different color sprinkle for each thing that they come up with for how to feel calm and safe. If you're doing this with a real live cupcake, if you're doing this with a real cupcake, they're motivated, students are often motivated to come up with more ideas because they want to put more sprinkles on, or they want to put more colors in there, extra cherries, things like that. So there's kind of a way of motivating them to come up with additional ideas. The I am, that might be the frosting, pick a color that represents who you are, and let's frost that cupcake that color. Some positive thoughts could be the cherry on top, or it could be sprinkles again. It could be different candies, however you want to do that. And then people who have helped me as well. So it's a neat little handout. To make it into a real cupcake, you're gonna have to get really creative with what kind of decorations you're going to use, all that kind of thing. So it would take a little more work to do that, but then you get to eat a cupcake afterwards. So, or you can do the handout and then serve, tree nut free cupcakes at the end. You can kind of celebrate the activity as a way of marrying both a handout, but also the ease of and enjoyment of eating a cupcake. The coping umbrella, so this shows my age, the Brock umbrella, the umbrella hat. I may or may not have worn one of these to the Derby years ago. So these are just cute little things. We had a Carnival Supply store up the street from where I used to live, which was amazing. And they sold packages of these. It was a dozen of them for like $15, super cheap. So this was an intervention I used with kids a lot. Because it was good for me, good for them, and easy to do and cheap. So the coping umbrella, what you do is with this, you have 1, 2, 3, 4, you have 8 sides, 8 colors. So you would have, the whole goal of this activity is to use the umbrella to help the client identify coping skills that they like and that they're willing to do. So for this, I would recommend having a menu of coping skills that they can pick from. With students that I've done it with in the past, I have had them try them out each day and have them and their teacher kind of keep track of what they like. And then the next week when I'd see them in session, we would either choose, did it work? Was it dumb? What do you think? I could have the best ideas in the world, but if my client thinks they're stupid, they're not going to do them. So it has to be something that they want to do. So I'm not going to sit there and write on the umbrella with a Sharpie marker and then have them go, well, that's a dumb idea, I'm not going to do it. Or think that they're just placating me and making me happy by saying, oh yeah, I'll take a deep breath, when they really think that's just not something they want to do. So I have them try it out. This is something that we go over. This would take multiple weeks and sessions. I used to have a sample that I would use to teach coping skills. And the way I did this with this one, this thing is beaten to all get out. But the way I would do this with this one is I had Velcro on each of the sections, and then I would have my coping skills laminated and then also color coded for my littles. So my color coded ones, yellow was a coping skill that they could do by themselves. So a child that's in a preschool classroom can walk away, obviously not leave the room, but walk away. But a child in a preschool classroom, this one says take a break. A child in a preschool classroom still has to get permission to take a break unless it's explicitly written into their behavior plan. So the way I identified them, and I made sure there was a balance of things that they could do on their own and things that they would need an adult's help with. So I would have all of these different coping skills on just a manila folder, so it was easy and transportable. And then I have my handy dandy Velcro umbrella, and we would try to put them on and we would practice them in session, and then they would come back the next week and they would choose if they wanted to keep it on the umbrella or rip it off. So it was a very empowering kind of event for them. They got to choose if it stayed, if it went. I think the way I did it with the last client I used it with, because she had a hard time choosing what she wanted to do. She had a separate umbrella. And once a coping skill stayed on the umbrella for like 2 or 3 weeks, that she was still open to it, that's when I put it on. And I actually had to draw pictures for her because she was younger. That's when I drew it onto her umbrella. When she finished with this activity, and this took 6 weeks. I mean, this was a bulk of her therapy. I was actually seeing her not for trauma, but for anxiety. So this was a huge part of hers, her treatment plan. Once she was finished with it, she owned that umbrella, and she emotionally owned that umbrella. She loved it, and she took it home and kept it. And it was something that, you know, stayed in her bedroom and just reminded her of what she could do when she was feeling nervous or out of control. So it worked really well for her. So that's the coping umbrella. And obviously you could get, I think, well, I don't know if Dollar Tree has umbrellas. I bet Goodwill has umbrellas for like a dollar or something like that. It doesn't have to be a hat. There's no reason they have to wear it on their head. I just think that's more fun. And like I said, I got them really cheap one year. Self-regulation swatches, speaking of cheap, it's a paint color strippy thing from Home Depot, Lowe's, Ace, wherever you want to go. They're free. Don't go and take a ton of them because that's rude. But you can go and take a few. So it's a free thing. The nice thing is there's different colors. I also like, depending on the brand of paint, the swatches might include only 3 colors for younger kids. And this one, obviously, in the example has, I think, 6. Yeah, 6 colors. So the older the children, the more regulation or coping skills you can put on there. Obviously, with this one, you could easily cut it in half or add to it each week. So just another cute little way of kind of helping students or clients identify different ways that they can calm down, that they can regulate themselves. All right. We did. All right. So that concludes stage 2 of the treatment goals for trauma therapy. Now we're looking at going into stage 3. Let me see. All right. So stage 3, soothing the physiology. So now that we have established that sense of safety, we've built rapport. That was stage 1. Stage 2, we've assessed and increased the client's coping skills. Great. We're doing well, right? We have kids up there ready to go off on the trapeze. We have our safety net secured. We still have their safety net under here. Now it's time to start getting into it, okay? So now what we want to do is find ways to start having them practice and soothe, regulate themselves, soothe their physiology, their physical responses, okay? This is where a lot of mindfulness will come in, a lot of mindfulness activities. It is important to remember, and I learned this the hard way when I first started working with clients that had experienced trauma. You know, I went in very innocently with good intentions, thinking like, this is our goal. We want to be calm. Okay, here's the deal. For clients that have cortisol racing through their system, to expect them to have all of that cortisol just drain out of them, that is actually going to be too big of a step for them. They are going to feel like they are out of control. They're going to feel like they're dying. Okay, you cannot remove their stress responses immediately. So if your client is up here just revving nonstop, soothing the physiology means that you're going for this, and then this, and then this, because you have to reduce the physiology, soothe that anxiety a little bit, and let this become the baseline. That is success. And then you take it down a little bit more, and you stay there until that becomes the baseline. And that's where they feel safe. and then you take it down a little bit more. So the idea is not to just go, we're not out there to make them little Buddhas. What we're doing is we're out there to kind of decrease some of the stress responses while they still feel safe. Okay, so it is a slow process that needs to go at the client's pace. And that's going to be cyclical, especially if related to the trauma, there's anniversaries coming up, there's court cases coming up, there is perpetrator getting out of jail. I mean, these are all things that kind of will come up and they're going to bump up and heighten them again. And it's going to happen. So it's not about decreasing. It's not about removing, rather. It's not about removing all the stress. It's about just decreasing and letting them know that they feel safe here. Okay. Just a little bit lower. All right. Let's see. Repetition. We talked about this a little bit earlier today. Rituals and repetitive actions are very calming and soothing for kids, helps them know what to expect. So adding rituals to your therapy sessions can be very effective, and help the client kind of step in and, if they're coming from this, the ritual of right now, my rituals all involve hand washing, because hello. So we do a lot of magic soap, but it's still, I will sing a song with them. Washing our hands. Again, I work with 3 to 5-year-olds, so bear with me. Washing our hands together, just a little singing song that kind of keeps them washing a little bit longer, because I want all their germs off of them as much as possible before they start touching things that have to then go into my car. So for those that are germaphobes, my heart, I'm a little bit of a germaphobe, and this whole pandemic just is anxiety provoking in and of itself. So finding rituals, ways of entering the playroom, ways of starting the session, ways of exiting the session, is all going to kind of remind them that even if they're coming from this, when they enter that ritual and they start going into the playroom and they enter that therapeutic process with you, physically, mentally, emotionally, they're going to come down a little bit. So it's a way of kind of helping them soothe. Okay. So some different rituals that can be easy, meaningful, good for you, good for them, easy to do, right? Tibetan, is that spelled correctly? Tibetan singing bowl. I guess so. It doesn't have the red underline. Use of a Tibetan singing bowl at the beginning or chimes can be a very nice way of just clearing the energy of the room. You can get Tibetan singing bowls on like Amazon, since we're all ordering online these days. I warn you, the quality will vary. So you're not going cheap on these bad boys. You're going to be spending $25 up for a nice Tibetan singing bowl that's really going to give you a good sound, a good tone. But having them just ding the bowl, they don't have to make it sing. I can't even make them sing on, most days. I've done it a couple times, but they don't have to make it sing. They can just hit it, and it just gives a nice sound. For Android phone users, they do have a mindfulness bell app. It is available in the Apple Store as well, but it's not as good. I don't like the tone as much. I have my things. But for Android users, there is a mindfulness app or bell app that is it's free, and it sounds really nice. So, even if you just have them hit your phone or you touch your phone, nice way to start and end the session. Wind chimes at the door of the playroom can be nice, just if they touch them, or even as the door opens, they're hanging on the doorknob. We have them at the front and back doors of our therapy practice downtown, just so we know when people are coming and going. But it's also just, it's become like a soothing sound. I kind of know I'm entering my workspace when I hear them. So it has become a ritual. It started out as a safety thing, but it has become a nice little ritual tone that we hear. We talked about washing hands or hand sanitizer. Not a bad ritual to do. And parents will appreciate not having their kids come out of the playroom with paint all over them as well. I touched on this briefly, just ways to enter and exit the room. So you can hop in. I've always wanted to do a sensory walk down the hallway so that kids could get some gross motor ritualistic movements in as they burn a little energy and start to organize their bodies and their minds before they enter the playroom. So a sensory walk would be amazing. They have a lot of ones on Pinterest that you can kind of cut out. It just depends on what your ability is to attach things to floors and walls, depending on where you are. So, but there's a lot of sensory walk options that you can do, or just hop or skip into the room, silly dance or anything. Maybe you strike a pose, get some little Madonna voguing in there as you go through the doorway. So just fun ways to just start the process and end the process can be very powerful. If clients do need ideas, you can have something on the wall, where they choose how they want to enter the room. So you can give them some suggestions. You don't want this to be like a sticking point and a stalling factor. This isn't, you don't need to take 15 minutes to get from the waiting room to your playroom. You want to get down to work. So you want these things to be somewhat quick. So if you need to have like a list of suggestions, a couple options for them to choose from, that will help them. Peacock feathers. I had one. I don't know, my cat, my kid, who knows? Someone took it. It's not in my bag right now. Balancing peacock feathers is awesome. When I saw it, I was like, that just doesn't, I wasn't impressed. When I did it, I was impressed. It's cool. So it's a great way to practice mindfulness. It's also, it's a good way to be aware of their surroundings too, because they're going to be focused. The whole goal is to have the feather balancing on your hand. I mean, you can get fancy and balance it on your forehead too. I would start with the hand, have them balancing the feather on their hand. But what they need to learn then, I'm trying to do this with a pen, it's not going to work, but they need to move a little bit. So that symbolically talks about kind of that implicit flexibility that we need to kind of have, go with the flow. So they're going to be moving around the room a little bit. If you're in a group, like is pictured down on this slide, you obviously want them to be aware of, like there's a pole in front of that kid. There's other bodies in your playroom. There's going to be furniture, things like that. So you want them to start realizing that they can focus. They can focus while moving a little bit, and they can multitask. They can focus while moving and still being aware of what's around them. So this really is a great thing. Kids of all ages love this. They feel very empowered by it. Even adults, I mean, we're all amazed at what we can do. So peacock feathers. These are the long ones. You want a full peacock feather. Don't get like the decorative ones. If you go to Michael's, they're already cut because it's for like a wreath or I don't know what hat. I have no idea what people use these for other than balancing and mindfulness. But apparently people do. So you want the full feather. You want this bad boy to be like 3 feet long. Otherwise, I'm not impressed if I can do something that's like 10 inches tall. I want the big one. So you want the full length of the peacock feather. The other thing that I have learned is you can buy them cheap on Amazon. Here's the thing. These are little facts, tips and tricks and crazy things that are stored in my brain. A lot of the cheaper ones, peacock feathers are not cheap. You're going to be paying, $2, $3 for one feather. They're durable. Okay. So they hold up. Now the one that's in my house right now that was taken by a kid or a cat, can't guarantee that one's still alive, or intact. But they do hold up. So, it's a little money, but it's okay. The cheapy ones on Amazon, a lot of them are preserved with formaldehyde and are really stinky. So you just want to be aware of that. If you do get some and they're super stinky, just kind of air them out and make sure that, you're not going to like have some horrible odor in your playroom. And, I'm personally allergic to formaldehyde, so I get a migraine immediately after I smell them. So you want to make sure that you are getting a good quality peacock feather. That is as much advice as I can give on those. Okay. Breathing. All right. Honestly, when teachers, parents are stressed, when we are stressed and we're like, just take a deep breath. Nothing says calm down like, calm down, right? So there's different creative ways of getting kids to take deep breaths. You have your square, right? Where you inhale for 4 seconds, you hold for 4 seconds, exhale for 4 seconds, hold for 4 seconds, okay? The whole thing about holding the breath is it keeps your kids from taking deep breaths and sounding like they're in Lamaze class. Okay, we're not trying to get our kids to hyperventilate. We're actually trying to bring the heart rate down a little bit. So getting them to do an activity where they're holding can be very effective. Star breaths are another way of doing that, where you make a star, where you breathe and hold on the inside of the star. You really have to have a physical star to like go around it. I can't do an air star to save my life. The hand, breathe in and out. Breathe in and out. So use what you got. You can make an air square, you got a hand. Those are great ways of slowing kids down. If they can't breathe in and out calmly because they're trying to go really, really fast, then you're going to say, breathe in and hold. And breathe out and hold. So there's ways of slowing them down. Take a breath. What I love about this one, especially with working with kids that have experienced trauma or clients that have experienced trauma, is it involves the senses. So imagining especially this time of year, think of your favorite kind of soup. So for me right now, it's going to be pumpkin squash soup because Breadco has it seasonally at this point. So you're going to have your soup in your hand and you're going to imagine it. And you ham it up for the kids, right? Like, oh, this pumpkin squash soup. Oh, it smells so good. I can smell the cinnamon. Let's breathe in and smell our soup. Now cool it down so we can take a bite and have them blow and cool the soup down. That works for soup. If you don't have a soup eater, pizza. I've had kids say, let's smell the pizza. I've had hot cocoa. Adults, it could be Starbucks, right? Coffee, love to smell coffee. So anything that kind of helps get their mind thinking about a smell or a memory, something soothing, can be really good. So they're smelling it in, and they're imagining they're smelling it in and breathing it out. If you do need to actually have a physical scent there, you can use a cotton ball. I'll use spice jars like the plastic spice jars. You can get a set of those on Amazon pretty cheap because they have the holes, but also because I work with younger kids, I put some essential oil on the cotton ball, just a couple drops, put it into the spice jar and seal it. Again, trust issues. Put that cap on there because I don't need them popping that, cotton ball in their mouth. I don't have time for that, right? Like Elf, the movie. So you can use an actual jar. A spice jar is great. That way you can also seal it up and they last for years. So you could have a peppermint one, you could have an orange one, you could have lavender if you want. There's a lot of different scents you can do. Coconut might help them think of the beach. So you can have a variety of them and they can pick one. For younger kids, a lot of my teachers in their rooms, they'll use chapstick. Obviously, if I'm going to put anything on a child's skin, I'm going to get clarification and okay from the parent or guardian. But they'll do smellies and they'll just put like a little wipe of a chapstick that come in. You can get tons of scents of those so the child can smell it that way. So that's kind of a neat way to introduce actual smell. Taking a deep breath, smelling the flower and blowing the pinwheel is a super easy activity you can do, actually make with kids. This one God bless America's. It's been around for a little while. Dollar Tree, cheap flowers. You can buy pinwheels in bulk. And you're just going to take duct tape or floral tape and wrap that flower so that it's all the way on there. This one isn't wrapped very well, and I wouldn't obviously have that for a client because I would be worried they would poke themselves with this. So you really want to wrap that all around. They're going to smell the flower and blow the pinwheel. So they get immediate feedback from this, which is really nice. Blowing the pinwheel can be frustrating. So it's okay to introduce frustration, right? We're trying to kind of bring them up or heighten them so that they can practice actually calming down. That's not a bad thing. You can also put a drop of some kind of scent on the flower if you want them to actually be able to smell something. Don't over scent this. One drop is more than enough probably to get them to smell something. You don't need them to like asphyxiate themselves, you know, and really going for it. So this is the smell the flower, blow the pinwheel that you can do. And then this other one is one that I've been using with my virtual students a lot this year, but it's exploding volcano. And I don't know why. I mean, it doesn't look that great to me, but my kids have really loved it. So I put it on there for you guys. So you start here, like at your namaste, and you're going to breathe in as the lava goes up. Take a deep breath in. And then it explodes. And you come back to namaste. So you come back to center, breathe in and out. They're responding to it. So there it is. Some different ways of breathing. Okay, there's more. There was a parent blog a couple years ago that recommended Imaginations 2. So there's more. I think there's a total of 3 imaginations, but they highlighted number 2. So clearly book 2 is the best. I don't have this one. I haven't bought it, but it was strongly recommended by parents that it might have been parents that were homeschooling their kids before, you know, all of us were homeschooling our kids. So tried and true, I trust the blog. But Imaginations 2, relaxation stories and guided imagery for kids. There's a ton of stuff on YouTube now too. Bubbles, we all know are great, not great when you're wearing masks and in a pandemic. So doesn't quite work at the same. Once we're past, hopefully we'll get past this COVID thing, blowing bubbles is great. You know, it really helps. They get immediate feedback on if they're blowing too hard or not enough. A good belly breath is going to give them the best bubble possible. You can't go cheap on your bubbles, man. Cheap bubbles just don't work. For mobile therapists, those wetting bubbles, not like the cheap janky ones, they're in a little tube because you can't get those tops off to save your life. But there's some that are in like a very thin vial, and they're probably about 3 inches long, skinny little tubes. So there's not a lot to spill if they do spill. They sell them at Dollar Tree for like holidays. They were in like the Halloween aisle. They're out there for Valentine's Day because I have a bunch of red ones, and you get like 8 to a pack, super tiny. Those are really good bubbles, and they're actually decent. You can really blow if you're doing groups and you're trying to get a lot of bubbles out there. But again, I can't blow bubbles in a mask. So I don't know about you guys. So there's a limitation to bubbles these days. A stethoscope. A friend of mine said that her son told his pediatrician that he liked her stethoscope. I mean, he was like 4, and she gave him a sample one. So you can buy some, but talk to your nurses, guys. Talk to your nurses. They know how to get stethoscopes that are real, that actually work. So the nice thing about that is, sorry, the alarm that if my daughter was in kindergarten, which she's not today, she's over at daycare, I would need to leave work and go pick her up. My phone tells me everything I need to know. So having a real stethoscope, the thought here is that the child can actually hear their heart rate. So one thing I've done with kids is I said, feel your heart. And, you know, I have them put their hand on their chest, feel their heart. They're not feeling my heart because as a woman, I have them feel their heart. And I might put, if they're comfortable with it, I'll put my hand over theirs, or I'll put my hand on their back if they're comfortable with that touch. but they can feel a child that's coming out of a meltdown can feel their heart beating out of their chest. I mean, they can really feel that thump. Or if you use a stethoscope. Now, the cheapy stethoscopes that you get online that are, like $10, you can't really hear a heartbeat. So they're not going to get any feedback from that. But for them to listen to their own heartbeat is kind of a cool thing. All right. So we are going to take a break from at that point, and we will be back in a little bit.